Hi everyone, I'm Dr. Sandeep Sharma and I welcome you to this part 6 revision session where I'll be taking up neurology scenarios. I'll also be taking up some nephrology sections and some miscellaneous scenarios as well. Before I start with the session, let me answer a question many of you have asked me. Sir, would something be asked from these scenarios and these discussions that you have taken on YouTube? I don't know. See, frankly, I do not know whether it will be asked or not. But what happened some months back was there is a FMG aspirant I know personally, and he said, "Sir, close to the exam, I have two options. Either I can revise all the other subjects, or I can revise medicine. Should I leave medicine?" I said, "Dude, don't do this, please, because medicine is one of the biggest subjects." But then I realized that compilation and revision in the last minute is something which is very tricky for everyone. I have been a student and it is a problem for most of you. So I thought that yes, I'm a pediatrician. I'll teach pediatrics, but I also love medicine. And so I thought, let me just create something which makes your life easy and which teaches you what is most important. It is not everything, yes, that is why I keep saying you should always be going through your notes. But who knows? There might be some questions being asked from these areas, and somebody who was planning to leave medicine, if you go through these areas, at least it will bridge that gap which was there, which you were creating by not revising these topics close to the exam. I do hope that all of you get great numbers, 200 plus numbers in the paper. But for someone who might be getting 148, 149 and he was leaving out particular systems of medicine, who knows, one of or two of these questions or one or two of these topics might be that gap might be filled by these topics which I'm discussing here. That is the whole rationale here. There are people who are brilliant medicine teachers here. My point is not to replace anyone. My point is I know my subject pediatrics, I also know medicine, and I know how to simplify, and that is what I'm trying to do here. So that is why I keep saying revise your own notes also, but don't leave out. Just try to give one or two readings before you sit in the exam. With this, let us start with the disclaimer, which I always give, that this session is not a replacement for your notes. But if you are planning to leave medicine, please, please, please go through them at least once. Who knows, questions may be asked, questions may not be asked. But end of the day, you have to read and revise all these key areas. So we will be starting with some scenarios in neurology first. We'll be starting with scenario number one. Now, scenario number one says, question will say, the examiner will say that there is an elderly patient. So something happened in old age and the patient is having severe headache in the temporal region. So severe temporal headache is there. There is raised erythrocyte sedimentation rate. So raised ESR is a useful clue. Fever may or may not be present. And the examiner will also say, which is a very important clue, there is a actual question asked on this, cord-like tender palpable temporal artery. So the temporal artery will be cord-like, it will be thickened, it will be painful to touch, and that will be palpable, not only visible but palpable also. So if you have a severe temporal headache in old age with raised ESR, with a tender palpable temporal artery, the likely diagnosis in the patient is going to be giant cell arteritis, also called as temporal arteritis. So this is the other name. Has a question on this been asked? Yes. If you look at past papers in FMG, there is a case scenario asked on this. So this is the first thing for today. If you get a case scenario, what are the keywords you will look out for? And the diagnosis will be giant cell arteritis. Now regarding giant cell arteritis, this is a picture where they will say, they will mark it like this, that this is there is a patient, there is an old age patient who's having severe temporal headache, raised ESR, and you can see that there is a tender palpable temporal artery in the patient. So let us do a quick review of the giant cell or temporal arteritis. First thing, it is more common in females than males, and mostly it is seen in elderly. In fact, there is a diagnostic criteria which also says that the age of the patient more than 50 years you should consider giant cell arteritis. It is not seen in young adults, it is not seen in children. Second thing is most common artery involved. Most common artery involved is superficial temporal artery. It's a past MCQ point as well. Superficial temporal artery, I hope you remember anatomy. It is a branch of external carotid artery. So it is a branch of external carotid artery. Not in FMG exam, but in NEET PG exam in the past, they have asked a question, statement-based question. All of the following are true about giant cell arteritis except one of the option was it most commonly involves branches of internal carotid artery. That is a wrong statement, and that was the answer. Why? Because giant cell arteritis may superficial temporal artery is involved, and which is a branch of ECA, that is external carotid artery. Other arteries can be involved, yes, but mostly it is the superficial temporal artery. Then what are the associations? Three associations you need to remember. First of all, they are associated with HLA-DR4, they are associated with HLA-DRB1, and they are associated with a condition called as polymyalgia rheumatica. Then the jaw claudication is a very specific sign. What is jaw claudication? Claudication means pain. So on prolonged chewing, there is pain in the jaw region, in the temporomandibular joint region. So jaw claudication is a very important clue here. And strokes and TIAs can also occur in patients with giant cell or temporal arteritis. Then sudden visual loss is a dreaded complication, and it can occur due to ischemic optic neuropathy in the patient. So sudden visual loss, sudden blindness can happen due to ischemic optic neuropathy in giant cell arteritis. It is a known complication. What is the investigation of choice? You will take temporal artery biopsy, and when you take biopsy, you will find three things. First of all, there will be pan-arteritis. Throughout the artery, entire thickness of the artery will be involved. Granuloma formation will be there, and a very important clue is fragmentation of the internal elastic lamina. If you look at Robbins mentions it very prominently. So fragmented internal elastic lamina. Some giant cells can also be seen. Granulomatous inflammation will be seen in the patient. And what is the treatment? Drug of choice in the patient is prednisolone. So giant cell arteritis responds to oral corticosteroid. Aspirin can be added to these patients. Are the other non-steroidal anti-inflammatory agents effective? Alone, they are not much effective. That is another clue that it is not the usual headache that we are talking about. And in severe cases or refractory cases, you can use tocilizumab. Tocilizumab is anti-interleukin 6 monoclonal antibody. ये अपने आप में भी pharma का question है that which among the following is anti-interleukin 6 monoclonal antibody? It is tocilizumab that you need to remember. So this is the key quick review of the topic giant cell arteritis. Let us move further and talk about the scenario number 2. Now scenario number 2 will say that there is a patient who's a young adult. And young adult patient is presenting with recurrent, pehla wala tha old elderly. Now this is a young adult patient who's presenting with recurrent attacks. Recurrent means again and again multiple attacks are happening. Severe headache, pulsatile headache, and unilateral. Very important clue. Severe headache, young adult, pulsatile. You can feel the pulsation, something throbbing inside, and on one side of the head, not the entire head. So unilateral headache, one restricted to one side of the midline. Secondly, duration will be more than 4 hours if you don't give any therapy. If you don't treat it, duration will continue for more than 4 hours, and it will be aggravated by movement. So patient will try to sit in a closed room in darkness and not he will not be fond of moving around or moving his head. It will be aggravated by movement, and it will be associated with nausea, vomiting, and photophobia. So as I said, person will try to sit quietly without any movement, keeping his head on the affected side like this, and he will be feeling pulsations happening on this side. For those, some of you might have unfortunately suffered from this. This is entirely fitting into a spectrum of migraine. There are two types of migraine: migraine without aura, where there are which is a common variety, and there is a migraine with aura. In aura, before the headache begins, there is also visual sensory symptoms. So two types of migraines are described. Fortunately, in FMGE exam, they either ask you to make the diagnosis or they ask you about the management of migraine. So that is where we will be focusing in this quick review. So these are the keywords you will look for in migraine. So migraine में young adult patient having unilateral headache, throbbing, pulsatile, severe in nature, associated with nausea and vomiting, and photophobia. Do you know that there is a diagnostic criteria for migraine? Yes. What is the diagnostic criteria? Have a look at this. They can ask you in the exam. All of the following are features of diagnostic criteria except. So they will say migraine diagnosis is made something like this. So this is a table which I have simplified for you. So there will be repeated attacks of headache lasting 4 to 72 hours. So the duration, if you don't treat it, it will last more than 4 hours. Normal physical examination, no other reasonable cause for the headache, and any two of the following should be there. That is unilateral pain, that is one side of the body, throbbing pain, aggravation by movement, moderate to severe in intensity. And any one out of these should be there, either nausea or vomiting, or photophobia and phonophobia. So photophobia will be intolerance to ambient light. Phonophobia will be intolerance to sharp noise. So patient will try to sit quietly in a dark room, right? So if you have a criteria being fulfilled like this, then you say the patient is likely to be suffering from migraine. Now, management of migraine is very important. So I will be writing it down, not showing the slide, writing, simplifying it for the entrance perspective. And some questions are relevant from the pharma part also. So it can be asked in paper B, it can be asked in paper A. The treatment can be divided into two parts: treatment of acute attack of migraine and a long-term prophylaxis or prevention. Okay. So सबसे पहले, first of all, we will talk about the acute attack. How you are going to manage acute attack of migraine. Whenever an acute attack of migraine comes, if it is a mild attack, the symptoms are tolerable, the initial agent of choice in the patient will be non-steroidal anti-inflammatory drugs. You can give a trial of either aspirin, or you can go for ibuprofen. Sometimes naproxen can also be used if available. So non-steroidal anti-inflammatory drugs may or may not be combined with a class of drugs called as metoclopramide. Metoclopramide or domperidone are sometimes added to these combinations because they take care of the nausea vomiting part also, and they have still they also have some role in the control of the symptoms of the migraine. So, but the first line agent, if someone asks you in the options, it will be non-steroidal anti-inflammatory agents. Suppose non-steroidal anti-inflammatory agents are not available, or it is a patient with a peptic ulcer, then alternative option in these patients will be paracetamol. There are combinations where paracetamol is combined with caffeine, and it is combined with sometimes metoclopramide also. So that combination can also be used. So I hope you remember that paracetamol and acetaminophen are same. So these are the first line agents in a patient of mild attack. However, if it is a moderate to severe attack, debilitating attack, obviously these non-steroidal anti-inflammatory agents will not be feasible, and in these patients the class of drugs known as triptans will be found to be more effective. So the question arises, what are triptans? Triptans are pharmacology mentioned as selective 5-HT 1B 1D receptor agonists. There are many types of triptans available, and both the oral form or the parenteral form can be tried. Either oral or parenteral form can be tried. Now, two MCQs can be asked here. If they ask you what is the most commonly used triptan, particularly in a resource limited setting like India, it is sumatriptan. However, Harrison very clearly says that there are better agents with better bioavailability available, and so if they ask you what is the most efficacious agent, ये pharma question है, so most efficacious agent will always be rizatriptan, right? So either of the two. If none of them is there in the option and some triptan is mentioned, that can also be the answer. If the question says moderate to severe attack, what you are going to use. The important thing to remember is that these triptans, they have cardiovascular side effects, and these triptans are contraindicated in ischemic heart disease. So if there is a patient of MI or congestive cardiac failure or severe tachycardia due to some reason, or uncontrolled hypertension, you will avoid using triptans. Now, there are some agents, some rare patients who will not be controlled with triptans. So if triptans fail, suppose if triptans fail to control the attack of migraine, we have a class of drugs which are FDA approved. You can give a trial of oral gepants. These drugs belong to a category of drugs known as CGRP receptor antagonists. These agents are employed where triptans are not effective or they fail. So they can give a case scenario and ask you, triptans are not available, not effective, what agent you will try? The typical oral gepant which is available in India is rimegepant. Right? This is the management of an acute attack. There are other agents also, other therapies also, but this is a revision session, so I'm not going into some other rare drugs. Second part of therapy is if there are recurrent attacks of migraine, you need to start the patient on prophylaxis, also called as prevention. So if they ask you prevention या prophylaxis के लिए कौन से agent हैं which are commonly used, the important prophylactic agents which can be used, either of these agents can be used. They include first of all beta blockers, Example, propranolol can be used. सब नहीं use करने, either of these agents can be used. Secondly, you can go for anticonvulsants. Two anticonvulsants are allowed to be used. They are FDA approved for use, mentioned in Harrison. You can go for either topiramate or you can go for valproate. Then you can go for a drug called as flunarizine that has been approved for use for prophylaxis. Then oral J-pants can be used for prophylaxis also. And then we have oral antidepressants. Oral antidepressants which have been approved for use in migraine attack, they include amitriptyline, nortriptyline, and third is venlafaxine. So if you look at this slide which I have written here, I have covered the pharma part, I have covered the management part, and I have also covered if a case scenario is asked in a particular manner, what you are supposed to remember, right? So this is the management of migraine. Let us look at the next scenario. The next scenario number 3 will say that there is a patient who's having episodic or chronic headache, right? Usually we say chronic headache if headache is present on more than 15 days in a month, right? So episodic or chronic headache. This किस तरह का headache, what type of headache? It will be bilateral tight band like discomfort. ऐसा लगेगा किसी ने ऐसा पट्टी बांध दिया है and it is a tightened band around the forehead of the person. So bilateral and tight band like discomfort, and it will be mild to severe in intensity. It can be mild, it can be moderate, it can be severe, and there will the nausea, vomiting, throbbing, photophobia, all these symptoms will be rare to absent. There are some variants where they can happen, but generally when we talk about the common varieties, they are usually absent. So if you have a headache like this, clinical history like this, the likely diagnosis in the patient is going to be tension type headache. And if someone asks you what is the most common type of primary headache which is not related to infections or other parts, it is the tension type headache. Remember, tension type headache are very common in the society and their exact prevalence is actually unknown, right? So tension type headache, not many questions are asked. It's a clinical diagnosis. If they ask you about the treatment of tension type headache, the acute attack, you can use either non-steroidal anti-inflammatory agents or aspirin or paracetamol. Remember that triptans are not much effective here. So it's a useful clue that triptans will not be efficacious. If it is a chronic TTH, then the drug of choice will be amitriptyline. And when do you say chronic TTH? If the headache episodes are present more than 15 times in a month. So more than half of the month if they are happening, then we say chronic tension type headache is present in the patient, right? Important thing which is mentioned in Harrison, tension type headache seldom occurs due to mental tension. Although relaxation exercises, yogic practices, meditation, they do help in tension type headache, but they also help in other types of headaches. Tension type headache, whether actually tension is involved or emotional stress is involved, that is doubtful, and recent studies say it is less likely to be due to mental tension. Having said that, the symptoms mimic, and so just like any other headache, you can go for relaxation exercises, meditation, breathing exercises in the patient. But eventually therapy will have to be given, right? Because tension type headache, if you say, you would start thinking, na, I'll take less tension, so headache will not happen. That is not how it happens. It is a primary headache. Moving further, scenario number 4. Now scenario number 4, question will say there is a young adult male with cluster or group of headache episodes. Periodically these episodes will happen in a group. Then there will be a normal phase, then group of headache episodes will happen, then there will be normal phase. So there will be, in each episode of headache, there will be deep, severe retroorbital pain. So now can you see the pattern which is evolving? पहले केस में giant cell arteritis में temporal headache था with a palpable artery, right? Second scenario में migraine में you had unilateral headache throbbing in nature. Nausea, vomiting, photophobia, movement से वर्सन हो रहा था. यहाँ third was band like bilateral discomfort, and fourth में क्या हो रहा है? Periodic headaches हो रहे हैं, और headache जब होता है तो it will continue for many days. So cluster will happen or group will happen, and in each headache episode there will be severe pain retroorbitally, and lacrimation may be present in the patient, autonomic dysfunction, excessive perspiration, excessive salivation, these symptoms may be present sometimes, and patient is restless and moves about. It's the opposite of migraine. Migraine mein patient prefers to sit down quietly. Here patient is restless and he tries to walk around, walk around, walk around. If you get a scenario like this, the likely diagnosis is cluster headache. The points I have taken, every single point is important in one way or the other. So cluster headache is the likely diagnosis. Overall, cluster headache is a rare type of headache. What is the treatment of cluster headache? If there is an acute attack, you have to give oxygen. High flow oxygen is the first line therapy, and many acute attacks are aborted by early oxygen therapy. Along with that, triptans need to be given. If there is no effect, if they fail, then you go in for non-invasive vagal nerve stimulation. It is mentioned as NVNS. There are techniques available in medicine clinics, in neurology clinics, where non-invasive vagal nerve stimulation can abort. So there is a role of autonomic nervous system in producing cluster headache. Prevention can be done by, short-term prevention can be done by corticosteroids like prednisolone, and verapamil, which is a calcium channel blocker, can also be used. There is a monoclonal antibody which can be asked in the exam, galcanezumab, which is a CGRP monoclonal antibody for prevention. It has FDA approved for prevention of cluster headache. It is not approved for the acute treatment of cluster headache. And if you have to do long-term prevention, obviously steroids cannot be given for long-term. So long-term prevention, you can consider either verapamil, you can go in for vagal nerve, non-invasive vagal nerve stimulation, you can go for melatonin, and lithium has also been tried, particularly if there are coexisting other psychotic symptoms in the patient, right? So this is the fourth variety of headache, that is called as cluster headache. So 4 headaches are very important in the exam. One is your giant cell arteritis headache, second is migraine, third is your tension type, and fourth is cluster headache. And the fifth headache is actually a disease by itself. Let us look at the scenario number 5. Scenario number 5 will say that there is any age adult patient presenting with a sudden onset severe headache. This is not much information. Now the next point which I am going to show you is the clinching point, which will help you in the diagnosis. And there have been 2 case scenarios asked on this. Question will say, person said it was the worst headache ever. मेरी जिंदगी का सबसे खराब headache था. ऐसा headache आज तक नहीं हुआ. This was the headache which I have never experienced before in my life. So I'm translating in Hindi, I'm also saying it in English. Worst headache of my life ever, patient will say. It is also called as thunderclap headache. Thunderclap headache is the headache which begins acutely. I'm talking to you, suppose I have this problem. While talking to you, suddenly my attack will begin. I will hold my head like this, and there will be severe shooting pain, and maximum intensity will be attained within 60 seconds. So peak occurs in less than 1 minute. That is called a thunderclap headache. And there will be, if you check, there will be neck rigidity, neck stiffness, Kernig sign, Brzezinski sign. Signs of meningeal irritation will be present in the patient. So whenever you have thunderclap headache, adult patient, sudden onset, and nuchal rigidity present, the likely diagnosis is headache is due to subarachnoid hemorrhage. Blood leaking into the subarachnoid space irritates the nerve fibers, it irritates the spinal nerve roots and produces neck rigidity, neck stiffness, meningeal signs being positive. Right? Subarachnoid hemorrhage, very important. Now, regarding subarachnoid hemorrhage, what is the most common cause? If they ask what is the most common cause, overall most common cause is trauma. If they ask what is the most common non-traumatic cause, it is rupture of saccular aneurysm, which are also called as Berry aneurysms. Commonly, these Berry aneurysms tend to form on the circle of Willis. Now, what are the key points on SAH that you should know? Now, the grading of SAH can be done by 2 scales. There are 2 scales available for this. They can be done either on Hunt-Hess scale, or it can be done by a scale known as WFNS scale. So these scales, they can ask, they are used for what? They are used for grading of SAH. Now, what is the immediate investigation of choice if you are suspecting a patient to have subarachnoid hemorrhage? The investigation of choice will be CT scan. Which CT will be done? Contrast or plain? Plain CT scan of the head will be done, also called as non-contrast CT scan of the head. And if it shows blood present in the subarachnoid space, that is the hallmark, right? Lumbar puncture. What about role of lumbar puncture? Usually lumbar puncture is done if CT scan is not possible, and I hope you know that when you do lumbar puncture you should be careful that there is no raised intracranial pressure in the patient. So if you do CT, if you do it within 6 hours, so you will find bloody CSF. Within 6 hours of SAH, if you do it, it will show bloody CSF. Between 6 to 12 hours, now this blood which has released into the CSF, into the cerebrospinal fluid, that will start, the RBCs will start degrading, and conversion into derivatives of the RBC degradation like bilirubin and related compounds will start happening. So between after 6 to 12 hours, if you see, the CSF will be yellow in color, and yellow in color is called as xanthochromic CSF. So xanthochromicity is nothing but yellow color. That is why I have marked here in yellow. And maximum xanthochromia according to Harrison occurs at 48 hours, and depending upon how severe was the bleeding, it will fade in about 1 to 4 weeks, right? And if they ask you what is the gold standard investigation or of investigation which is a must before surgery, neurosurgery is planned, 4 vessel conventional angiography is the gold standard investigation. Now coming to the cause of mortality and morbidity. Many of the patients develop delayed neurological deficits. It is also mentioned as D&D. What is D&D? D&D is not a good thing to happen. D&D in SAH stands for delayed neurological deficit. A neurological deficit which occurs a few hours after occurrence of SAH. It does not present with the thunderclap headache. It occurs few hours after an attack of SAH. Now, what are the 4 important causes of SAH? The first important cause is re-rupture. Many times repeated rupture will happen. If you don't do neurosurgery in the patient, there is a 30% risk of another hemorrhage happening in untreated SAH within 1 week. And re-rupture increases mortality manifold. It carries a poor prognosis. That is why every SAH you need to consider surgical opinion in the patient. Earlier the concept was conservatively managed. Now we do conservative management, but we also go in for neurosurgical intervention within 1 week of the rupture. So this is the first reason for delayed neurological deficit. Second, hydrocephalus. I hope you all know what is hydrocephalus. Hydrocephalus will be a dilatation of the ventricles, increased CSF volume, and this hydrocephalus can cause features of raised ICP, which can again cause delayed neurological deficit. So, agar patient mein delayed neurological deficit is happening, one cause, again it has ruptured. Second cause, hydrocephalus. Third cause, very important, which is also the cause of death in SAH, delayed cerebral ischemia. It is written as DCI. What is delayed cerebral ischemia? After an attack of SAH, particularly a big SAH, there will be vasospasm of the central vessels. There will be vasospasm of the neuronal vessels, and that will cause delayed cerebral ischemia, and this is considered to be the most common cause of death. Harrison says major cause of mortality and morbidity in SAH is vasospasm caused by delayed cerebral ischemia. So it can be a potential MCQ one-liner. And fourthly, hyponatremia can cause delayed neurological deficit. It can cause seizures in the patient. It can cause ICP changes. It can cause altered sensorium and low GCS. हाइपोनेट्रीमिया क्यों होता है? देयर इज रिलीज ऑफ एट्रियल natriuretic peptide and brain type natriuretic peptide. It produces cerebral salt wasting syndrome. There is hyponatremia, and levels below 125 milliculant per liter can precipitate acute crisis in the patient. So these are the 4 important causes, delayed neurological deficit, and they are the ones responsible for the immediate death or long-term problems in the patient. So what is the treatment of SAH? Treatment of SAH will be immediate treatment. If a patient develops SAH, what you are going to do? Nimodipine should be given. Nimodipine has been shown to reverse or reduce the chances of vasospasm. After, along with usual, the usual management you will do for any emergency that you do, ABC, management of raised ICP, putting a IV line, all these things you will do. But nimodipine always has to be added, followed by repair. Neurosurgical repair should be done within 24 hours to reduce the chances of re-rupture in the patient. And when you are doing surgical repair through neurosurgery, you can consider either endovascular coil placement in the bleeding vessel. You identify and place a coil in it, or you apply clips on that. Right? Which is better? Again, it more depends upon the patient, the cause, and the expertise of the neurosurgeon. If you compare them, many texts say that endovascular coiling is superior, but again it will come down to both of them are approved for use. It comes down to the patient as well as the expertise of the neurosurgeon who's operating. So this is the quick key review on the topic of SAH, and have a look at this NCCT. If I say this is NCCT in SAH, what you are going to look for? Two things I can see here. I can see bleeding happening in the sylvian fissure. I can see bleeding happening in the basal cistern, right? Let me show you where is this bleeding happening. Can you see this blood in the sylvian fissure? And can you see this blood in the basal cisterns? This is the clinical clue on CT scan that SAH has happened in the patient. Let me just remove it again and see. Right? Have you seen? Now I'm again highlighting it here. So you can see blood in the sylvian fissure, blood in the basal cistern. This is how NCCT will look like in SAH patient. I hope you will not forget it if you get a image like this in radiology part. Other types of intracranial hemorrhage, there are many types. We have intraparenchymal hemorrhage, we have other rare forms also, but two varieties, differences between them are asked. It's a medicine surgery overlap. So the two varieties are extradural hematoma and subdural hemorrhage. So let us do distinction between them. First of all, laterality. Extradural hemorrhage or extradural hematoma is unilateral, whereas SDH is either unilateral or bilateral. Then regarding the source of bleeding, EDH, usually the bleeding arises from middle meningeal artery. There is a past MCQ on this. SDH arises from the bridging cortical veins in most cases. Regarding the presentation, EDH patient, there is a lucid interval which is present. So apparently normal period of normalcy followed by progressive deterioration is present. So again a MCQ one-liner. On the other hand, headache, confusion, progressive neurological deficit, lucid interval rarely present, but it is usually absent in patients of SDH, right? There can be overlap cases, there can be mixed cases where lucid interval can happen in SDH, but generally if you get a case scenario, lucid interval mentioned, you will think of EDH and not SDH. And then association with skull fracture, EDH has association with skull fracture, SDH usually no skull fractures are found. Then patients of EDH, extradural hematoma will be limited by the suture lines, whereas SDH will not be limited by the cranial suture lines. Then if the question says what will be the shape on CT, the shape on CT scan here will be biconvex, whereas SDH will be crescentic shape, also called as concavo-convex, also called as banana shaped. It is also called as lemon shaped. This is also called as banana shaped. So lemon sign on CT scan, banana sign on CT scan. Lemon sign seen in EDH, banana sign seen in SDH. There are mnemonics for that. I hope you have read about them, right? Surgical drainage, EDH, it is needed. SDH, it may or may not be needed. On EDH का बड़ा simple funda है, the earlier you evacuate extradural hematoma, better is the outcome. So what is the prognosis or outcome? EDH, it depends upon how fast surgically corrected. If you correct this it immediately and there are no coexisting problems, patient can survive and there is a good outcome. SDH, even if surgically corrected, if it is a massive SDH, there will be post-operative complications, and usually SDH, EDH versus SDH, despite surgery, it has a poor outcome, provided it is a large SDH, right? And now have a look at this NCCT image. This NCCT image is showing you the lemon as well as banana sign. What is the lemon sign? Look at this. Can you see this biconvex image here? This biconvex image, which is a which is like a lemon. It is looking more like a lemon. If I have to show a lemon, the lemon will be looking something like this, right? Although the lemon that we have in our country, they tend to be more rounded, but there are certain varieties of lemon which are more elongated, and this is what you call as the so-called lemon sign. So lemon sign on CT scan, non-contrast CT scan, will be suggestive of extradural hematoma or extradural hemorrhage in the patient. On the other hand, can you notice, can you see this image which is happening, this concavo-convex or lenticular image which is happening? This is looking something like this. It is starting from here. Let me just mark it here. It is starting from here and it is coming all the way till here. So this entire part is what is called as the banana sign. This is the banana sign, and if you find banana sign on CT scan, the likely diagnosis in the patient is going to be subdural hemorrhage or subdural hematoma. So we have lemon sign and we have banana sign. And also remember that when you do a CT scan and you find that it is a whitish colored or it is a hypo intense image or hypodense image, it indicates acute bleed. On the other hand, when it becomes darkened in color, that will be considered to be a chronic bleed. So if it is a white lemon sign, it will be acute EDH. If it is a dark lemon sign, it will be a chronic bleed or chronic EDH. Likewise, if you have a white banana sign, that will be acute SDH. If you have a dark colored banana sign, that will be chronic SDH, right? So this is all you need to know regarding this topic. Let us move further and talk about something which many of you are literally afraid of, and I know some of you have decided not to go into the details of the topic. See, it's a huge topic, it's a difficult topic. But if you look at the FMG exam, you find that there is a way questions are being asked. So I will not be overburdening you with information, but I will be discussing some flowcharts, some scenarios, and some one-liners which will make life easy for you. And my sincere advice, after finishing this video, after 12 to 24 hours, watch this video again in 2x speed or 1.5x speed and keeping the PDF in front. And you will notice that the retention of yours before you sit in the actual exam will increase. So stroke and TIA, TIA stands for transient ischemic attack. Both stroke and TIA are included under the group of conditions called as cerebrovascular diseases. Just like you have cardiac diseases, you have the cardiovascular diseases. Similarly, we have the cerebrovascular diseases, also sometimes written as CVD. So what are cerebrovascular diseases? So any patient who is having an abrupt onset, so acute onset of a new neurological deficit due to a likely focal vascular cause is called as a cerebrovascular disease. There are many subtypes, but broadly speaking, there are two subtypes that you need to know. The first variety is called as transient ischemic attack. What is a transient ischemic attack? TIA will be like a stroke patient, but all the neurological signs and symptoms, the deficits which happen, they will resolve within 24 hours. Harrison says that usually they resolve within 1 hour, but can persist sometimes up to 24 hours. You will call it as TIA, a reversible kind of injury. Whenever all neurological signs and symptoms which had appeared, they resolve within 24 hours of the onset. And when you do neuroimaging like CT or MRI, you will find no evidence of brain infarction. So infarct in the brain, neuronal infarct will not be found. So this is called as a transient ischemic attack. It's a self-limited illness. On the other hand, if you have a patient where neurological signs and symptoms persist more than 24 hours or neuroimaging shows evidence of brain infarction, neurons are dying, you will call it as stroke. Stroke का other name है cerebrovascular accident. तो समझ लो कि there is an entity known as CVD, cerebrovascular disease. ये दो तरह की है, TIA and stroke. And stroke is the form which is also known as cerebrovascular accident. So sometimes examiner क्या बोलेगा, he will put cerebrovascular accident word. So you should understand that the stroke phenomena is being talked about, right? So these are the two broad subtypes. Now, what is the risk of stroke after TIA? Now, obviously, if a patient has TIA, the risk of stroke is increased, and the risk of stroke is maximum in the first 48 hours. And this risk can persist for as long as 3 to 6 months. So there should be a scoring system for that. And yes, there is a scoring system. The scoring system is called as ABCD2 score. Components of ABCD2 score was asked in July 23 FMG MCQ. So it's a recent past question. So एक patient में TIA has happened. What is the risk of stroke after that episode of TIA? That is predicted by ABCD2 score. So what do you need to know? First of all, you need to know the components of the score. So look at this table. This says that there are 5 components of this table, and pointing and scoring is done accordingly. So A stands for age in the patient. So A stands for age. So if the age is more than 60 years, you give a score of +1. Otherwise, if the age is less than 60 years, 0 point. So no score is given. If the BP is equal to or more than 140/90, you give a score of 1. Then we look at clinical feature. In case there is only speech slurring, speech disturbance, but no motor weakness, you give +1. And in case there is a unilateral one-sided weakness, you give a score of +2. Then we look at the duration of the symptoms, duration of the deficit. If the duration is between 10 to 59 minutes, if it is less than 10 minutes, no score. 10 to 59 minutes, give one score 1, and if it is equal to more than 60 minutes, give a score of +2. And then if the patient is a diabetes mellitus patient, you give a score of +1, and then you take the total calculated score. Now what is the interpretation? Interpretation, if you try to Google, a lot of random information is given. What you need to know from entrance perspective is what Harrison says. Harrison is the final authority in medicine, and Harrison very clearly says that this is the interpretation. This is the chart taken from the resource which Harrison also has quoted. So it says that what is the ABCD2 total score? If the total score is 0, the 3-month risk of stroke in percentage is 0%. If the total score is 1, there is a 2% risk of stroke. 2, there is a 3% risk. 3, risk is 3%. Total score is 4. There is a 8% risk of stroke happening within the next 3 months. If the total score is 5, there is a 12% risk of stroke. 6, there is a 17% risk of stroke. And 7, there is a 22% risk of stroke in the next 3 months. So this is, now, should you be remembering everything? Ideally, yes. Practically, this table is the one from which new questions can be asked. And also remember that the maximum risk prediction for 3-month risk of stroke is given if the total score is 7, and 7 gives a value of about 22%. If nothing you can remember at this short point before the exam, at least remember this fact taken from this table. So this is the risk of stroke after TIA predicted by ABCD2 score. If you look at the past FMG paper, there is a trend. There will always be 1 or 2, sometimes 3 to 4 questions asked from scoring system. So scoring systems in medicine, pediatrics, surgery, radiology, and sometimes also in your various oncology parts like pathology and related subjects. Whatever important ones you go through, you must remember them. Just like we did the child Turcotte-Pugh score and MELD score in the video on hepatology, right? So this is the risk of stroke after TIA. Let us move further and talk about the management of stroke. Now it's huge, so I will be just compressing the information and trying to give you what you need to remember from exam perspective. So सबसे पहले, how would you know, when would you suspect the stroke is happening? So any patient who's having acute onset neurological deficit and no other cause is found, you should assume that it is likely to be stroke. And what is the mnemonic which raises the suspicion of stroke? There is a mnemonic that you need to remember. The mnemonic is called as FAST. FAST is mentioned in many textbooks and many guidelines also. FAST says any patient who's having face, F stands for drooping of the face to one side, any weakness in the arms, any difficulty in speech, that indicates stroke is likely. And so these patients, T stands for time to call and refer to emergency. Right? In the Western world, they call 911. In Indian setting, you take the patient urgently to hospital, assuming stroke has happened. Right? So stroke patient comes to the hospital. What is the first thing that you are going to do? Obviously, like any other emergency, you will be first managing the airway. You will be looking at the breathing pattern in the patient, and you will be ensuring circulation in the patient. So airway, breathing, circulation will be ensured, and immediately performed urgent NCCT. NCCT stands for non-contrast CT scan of the head should be done. NCCT scan takes less time. It is available at most centers, even at odd hours. So NCCT should be done immediately. The purpose of NCCT is not to pick up stroke, but it is to see whether hemorrhagic stroke has happened or something non-hemorrhagic is there, because your management will be totally different. Now NCCT, if you do, there will be 2 possibilities which will happen. When you do CT scan, if you find that the patient is having hemorrhage which is present, then it is likely to be a stroke which is called as hemorrhagic stroke. Hemorrhagic stroke usually occurs due to intracerebral hemorrhage, and these patients, there is no thrombolysis which should be done. So remember, hemorrhagic stroke, what will be the clues in the MCQ or in the case scenario? Question will say that the patient is hypertensive. So hypertensive patient, often having BP, at the time of presentation equal to or more than 160 by 100, you should assume that it is likely to be a hemorrhagic stroke. And when you do CT scan, you will find that there is bleeding present. Where is the bleeding present? The most common site of bleed in a hypertensive stroke patient or hemorrhagic stroke patient is in the putamen part, in the basal ganglia. So most common site, it's a past one-liner also. What is the most common site of hemorrhagic stroke or intracerebral hemorrhage due to hypertension? It occurs in the putamen. Remember this, putamen is the site in the brain and it is usually on one side. So unilateral putamen bleeding is the most common site. Remember, in hemorrhagic stroke patients, there is a case scenario question also asked on this. Thrombolysis is absolutely contraindicated. So thrombolysis is contraindicated. Thrombolysis nahi karna hai. Alteplase should not be given in these patients. There are 2 past MCQs on this. So thrombolysis should not be done. So kya karna in patients ke andar? In these patients ke andar, what will be the management? The treatment will be, you will do BP control because hypertension has caused it. Plus you will do management of raised intracranial pressure, just like you do for any raised intracranial pressure management, keeping in mind that cerebral blood flow should not be compromised. And then in case you find that there is a large space occupying hematoma, if there is a large space occupying hematoma more than 3 centimeter, especially in a region that called as cerebellum, then you can plan neurosurgical evacuation. You can plan neurosurgical evacuation, right? So this is the management, broad management you would do in a patient of hemorrhagic stroke. Question has also been asked in one way, कि a patient of hemorrhagic stroke has happened, they made a case out of it, and which should not be done. So thrombolysis should not be done. BP management and supportive measures have to be given in the patient. Now in case you find that there is no hemorrhage, there is no hemorrhage in the patient, but stroke is suspected. So there is a possibility it is likely to be a thromboembolic or ischemic stroke in the patient. So in these patients, you will see how much window period do you have, how fast the patient has presented. If the patient has presented within the window period of equal to or less than 4.5 hours. Now the new edition of Harrison very clearly says the benefit is there till 6 hours also. So if the MCQ is framed in that way, so you would write like 4.5 to 6 hours. But if you look at other standard guidelines, they say window period is only up to 4.5 hours. So within 4.5 hours, the patient has presented and there is no hemorrhage. So kya karenge? In these patients, you will perform immediate urgent thrombolysis. Thrombolysis is the therapy of choice. And thrombolysis is done using recombinant tissue plasminogen activator, also called as alteplase. Right? In case you find that the window period is prolonged, but a stroke is, but an ischemic stroke or an infarct is present, so window period is crossed, it is more than 6 hours, then you will check for perfusion. Check for perfusion. This checking for perfusion you should be done using MRI or other neuroimaging techniques, and consider endovascular revascularization. Endovascular revascularization. There can be fresh questions created on this. Endovascular revascularization is nothing but using an endovascular technique. You will do mechanical thrombectomy. Mechanical thrombectomy. Thrombus को remove करने की कोशिश करेंगे. In case you find that there is a patient where a large thrombus is present, particularly in a very large artery, and thrombolysis is contraindicated or it has failed, there also you will consider endovascular revascularization, that is mechanical thrombectomy. So if thrombolysis fails, then also you will consider this process. Now if you look at this flowchart, it's a very simplified flowchart compared to the flowcharts which are given in your guidelines and textbooks, but this covers a lot of past MCQs and many case scenarios. So just remember this flowchart and it will make life easier for you. Obviously if you get a difficult case scenario, Practical life, we don't exactly follow this. There are some ifs and buts and stars and some disclaimers which always come into play, but generally these are the guidelines which you tend to follow. It is based upon Harrison 21st edition that I am discussing here, right? So this is the management of stroke, very important. I did not want to show you a table, I wanted to write it down. I hope you remember it, right? Let's move further. Now, talking about the dose of alteplase or recombinant tissue plasminogen activator, it has been asked. If you look at the recent papers, dose has been asked in FMG exam. In an old question as a numerical, it has been asked in NEET PG also. So what is the dose of alteplase which is recommended? So remember that whenever you have to do thrombolysis, IV route should be used. When you are using IV route, 10% dose will be given bolus, 90% will be given as infusion over 1 hour. Okay, so the total dose is given by the formula 0.9 milligram per kg. The maximum dose which can be given is 90 milligram. And when you give IV, as I said, 10% will be given as bolus and remainder will be given over 60 minutes after that. And what are the indications and contraindications for alteplase? This has also been asked. So this is a table which has been taken from a reference given in Harrison. So it says that if there is a clinical diagnosis of stroke, the onset of symptoms to time of drug administration, the window period which I told you, it is within 4.5 hours. CT scan is showing no hemorrhage or edema more than 1/3 of the middle cerebral artery territory. It's a radiological criteria. And age of the patient should be an adult patient, 18 years and above. That is the indication of using alteplase. So alteplase is not recommended for use below 18 years. And what are the contraindications? In case the patient is having a sustained high BP despite treatment, there is a bleeding disorder, there is a coagulation problem, there is a recent head injury or intracerebral hemorrhage has happened, there is a major surgery in the preceding 14 days, you will not use alteplase. It can cause secondary bleeding after that. GI bleeding in preceding 21 days, you should avoid it. And a recent MI patient also, you should avoid using alteplase. So this is the indication, contraindication, and the dose, and questions have been asked on them. Now moving further, there are some brainstem stroke syndromes. Now stroke syndromes, see, they are important, yes, but I personally feel we give too much weightage to brainstem stroke syndrome. At the most, one question is asked, and the details of which pathway is getting involved, although that is the ideal way to read them, but close to the exam, you should only be focusing on the important ones and how to identify a particular brainstem stroke syndrome. Now, brainstem stroke syndromes include some named syndromes. One of them is Weber syndrome, on which components of Weber syndrome was asked in MCQ 2019 in FMG exam. So what is Weber syndrome? The patient, when will you suspect Weber syndrome? If the patient is having ipsilateral, same-sided oculomotor, that is third nerve palsy, and contralateral, also called as crossed hemiplegia, that is Weber syndrome. And Weber syndrome arises due to what? It arises due to involvement of the posterior cerebral artery. There is a posterior cerebral artery, particularly the P1 segment involvement. Involvement of this particular artery leads to ischemic stroke, producing Weber syndrome in the patient. Secondly, what is Claude syndrome? In case patient is having ipsilateral third nerve palsy with contralateral opposite-sided tremors, that is called as Claude syndrome. And third, we have the Benedict syndrome, which looks like a combination. So it's a ipsilateral third nerve palsy, which is usually incomplete or partial. Rarely it can be complete third nerve palsy on one side, and contralateral weakness along with contralateral tremors in the patient. And the fourth one is Millard-Gubler syndrome. It has been asked 2 times in the non-FMG papers like INI-CET and NEET PG. It has been asked. So Millard-Gubler syndrome will be ipsilateral facial weakness and contralateral hemiplegia in the patient. So these are the important 4 syndromes you must remember before you sit in the exam. Moving further, there are some fundas to remember. What are the fundas to remember? First thing is, in case a patient is having a left middle cerebral artery stroke, ischemic stroke involving the left-sided middle cerebral artery, the clinical presentation will be similar and there will be aphasia, but the type of aphasia will give you the clue what is the likely diagnosis. So if the question says there is a patient having contralateral palsy of the muscles, so hemiplegia on the opposite side, and Broca's motor aphasia is there. Broca's motor aphasia, I hope you know that there are multiple types of aphasia. Aphasia means reduced verbal output. It can be Broca's motor area where understanding is there but speech output is not there. And then we have sensory Wernicke sensory aphasia where the interpretation is lacking, although fluency may be retained. And then there are global aphasias, there are anomic aphasias, multiple types of aphasias have been described. So if the question is saying contralateral palsy with Broca's motor aphasia, where is the problem? It is in the left middle cerebral artery, superior division. Superior division supplies to the Broca's area. On the other hand, in case question is saying contralateral palsy with Wernicke's aphasia, if you get a case scenario like this, similar case scenarios have been asked in the NEET PG and INI-CET kind of exam, right? So you know the exams are merging. I'm not going overboard in trying to tell you the detail, but these are clues. तो अगर बोले कि contralateral palsy है, contralateral hemiplegia with motor aphasia, which type? Broca's type. So you will remember it is superior division, and if it is Wernicke's type, it is inferior division of left midcerebral artery which is involved. Now that we are talking about aphasia, I hope you remember the three broad types of aphasias. So we have the Wernicke's aphasia where the comprehension, understanding, comprehension means understanding, speech को understand करना, whatever they are going to say. So understanding is impaired. So understanding is affected. Repetition is also impaired. Naming, they are unable to name, that is also impaired. But the fluency is preserved or increased. बोलने में problem नहीं है. Fluency, speech output is normal, but difficulty in understanding the speech and the words which they are making, that is called as Wernicke's aphasia. Then we have Broca's area where comprehension, understanding is preserved except grammar, but the fluency of the patient is decreased. So output of the motor words, that is impaired. And what is global aphasia? Everything will be impaired. Comprehension, fluency, repetition of language spoken and naming, they all will be impaired in the patient, right? Now moving further, there is a variety called as anomic aphasia. MCQ on this has been asked in FMG exam. Anomic aphasia, the name itself is suggestive. नाम नहीं ले पा रहा है. The person is unable to recall and speak out the names of the objects. So anomic aphasia is difficulty in naming an object or finding phrases to explain an object. Spelling is also often impaired in the patient. And MCQ 2018 FMG exam. Have you seen those people who would be like, Arey, I was going to tell you something. There is a name I'm remembering. We often forget names of the things. But if you forget names of most of the things, common things which you are not supposed to forget, and that kind of aphasia is happening regarding most of the common things, that is called as anomic aphasia. Anomic aphasia is seen in multiple conditions. First of all, it is seen due to post-head trauma. Secondly, it can occur in Alzheimer's disease. This is a NEET PG question. And the question which was asked in FMG exam was, it can also be seen in metabolic encephalopathy. So metabolic conditions like uremic encephalopathy and high ammonia as a part of metabolic disorder, that can also produce anomic aphasia. So the separate slide I have put so that if your question is repeated, topic is repeated in some manner, you don't go wrong here. Now some miscellaneous one-liners. Look at the first one-liner. Bilateral occipital lobe infarct produces a syndrome called as Anton syndrome. Anton syndrome is an interesting syndrome in the sense that there is cortical blindness. Patient cannot see, but he is not aware. He denies that he is blind. That is called as Anton syndrome. And bilateral occipital lobe infarction is the reason. For TIA, transit ischemic attack, we have done the ABCD to scoring, but should you be starting patient on something because the risk of stroke is increased? Yes, you should start the patient on antiplatelet therapy. Along with antiplatelet therapy, most of them are having hypercholesterolemia also, so statins should be considered. And if the patient is hypertensive, BP control is plus minus. When you consider antiplatelet therapy, we always go in for dual therapy. Dual therapy means aspirin is the drug of choice, that is the favored agent, but aspirin combined with ticagrelor is always found to be a superior alternative, right? So dual therapy should be started in TIAs for prevention of the stroke. And what is the most common cause of acute ischemic stroke occurring by emboli? The underlying reason is atrial fibrillation, which is a non-rheumatic atrial fibrillation mentioned in Harrison. It's a one-liner, you need to remember it. Then aspirin is useful in ischemic stroke, but it is not started within the first 24 hours, always start after the thrombolysis is over. So two types of questions can be asked to you. Does aspirin have a role in the management of ischemic stroke? The answer is yes. Is aspirin given acutely in the management of ischemic stroke? Not immediately. It is given 24 hours after thrombolysis has been done. Right? Clear? So depending upon how question is asked, you may get question on this. Statement based questions have been asked in the other exams. So that is why I am emphasizing this point here. Then now have a look at the image asked in MCQ exam December 2020, and the interpretation is not correctly mentioned in some of the uh, resources that you would have read. So there was a question where they said that a draw the clock test was done. When you ask a person to make a clock, a round clock, and all the numbers on that, and we tell him to make it and show it to us, and the patient makes a clock like this, what is the likely diagnosis? The patient is having a phenomena called as hemi-neglect. So remember, this is hemi-neglect which is being shown here. Which hemi-neglect is there? Can you see that the left side of the patient, he has omitted out all the detail. On the right side, there is a clustering of all the numbers which has happened. And you would be surprised to know the patient himself or herself does not know that this is happening. You ask them, ki, have you made the clock right? He or she would say, yes, I have made the clock right. But instead what has happened is all the numbers have been clustered on the right side. This is called as left hemi-neglect. So if they ask you, this photograph is showing what kind of clinical phenomena, it is showing left hemi-neglect. And name one common cause of left hemi-neglect. Potential MCQ point, I'm putting a star. Right parietal lobe, right parietal cortical lobe or cortical infarct is responsible for left hemi-neglect in the patient. There can be many reasons, but this is one of the common causes of why left hemi-neglect can be produced in a stroke patient. It can occur in stroke. It has also been described in certain progressive dementia disorders, but here left hemi-neglect is seen. Now we have talked about the ischemic strokes, but hemorrhagic stroke also, a lot of questions are asked in the exam. So let us do a quick review here. Hemorrhagic stroke. What is the most common risk factor? I hope you already remember that it was hypertension which was the most common cause. It can also occur due to trauma, coagulopathy, aneurysms, and cocaine abuse in the patient. Secondly, most common site of hemorrhagic stroke is in the basal ganglia, especially putamen is the site where hemorrhagic stroke manifests. And it presents with, how is the presentation? Acute onset, one-sided weakness, hemiparesis or hemiplegia in most of these cases. And NCCT is found to be highly sensitive. That is why when the stroke patient was coming in the management, I told you first you do CT and decide hemorrhagic versus non-hemorrhagic, because CT scan, non-contrast CT is very sensitive in picking up even small hemorrhages in the patient. So NCCT is highly sensitive. And look at this image. And they will show this image and say this was a patient who presented with acute onset unilateral weakness, very high BP was present. What is the likely diagnosis? So white colored bleed, acute bleed has happened in the basal ganglia and putamen region here. So this is likely acute hemorrhagic stroke which has happened, because there is hemiplegia also present in the patient. So this is how hemorrhagic intracerebral hemorrhage in the putamen basal ganglia region looks like. It is usually unilateral, rarely it can be bilateral also. And management of hemorrhagic stroke, we have already discussed it. Now, hemorrhagic stroke, localization of bleed, sometimes questions can be asked, and Harrison gives a lot of weightage to it. So in case bleed happens in the putamen, so patient will be presenting with contralateral hemiparesis. If the bleeding happens in the thalamus, patient will have contralateral hemiparesis with sensory loss. We call it as hemianesthesia. There will also be aphasia and visual field defects present along with it. Sometimes thalamic involvement also produces a rare syndrome called as Jerry-Rusi syndrome, but that is a rare manifestation. Then we have pontine hemorrhage, old MCQ point. Please remember, I'm putting a star. Pontine hemorrhage produces pinpoint pupils, small constricted pinpoint pupil. There will be deep coma in the patient and there will be quadriplegia. So pontine hemorrhage is the one which has high mortality. All four limbs are involved, deep coma, very low GCS, pinpoint pupils are characteristic. Then cerebellar involvement will cause occipital headache, vomiting and ataxia in the patient. And occipital lobar hemorrhage will produce hemianopsia, which is a severe type of one-sided unilateral absent visual field in the patient. So visual field defect of hemianopsia will be seen in occipital lobar hemorrhage. And then we have this score called as ICH score. There is a score here also. So ICH score, it predicts mortality in hemorrhagic stroke or intracerebral hemorrhage patient. There are 5 components of this and scoring is done. So what is the ICH score? So this is the ICH score. So first component of ICH score is look at the GCS. Then we look at the ICH volume, how much hemorrhage has happened, then whether intraventricular hemorrhage, extension into the ventricular space, has happened or not, whether it is infratentorial or supratentorial, and we look at the age, whether it is less than 80 or equal to or more than 80, and then we take out the total score. And if you see, higher the score, poorer is the outcome, more is the mortality. So the lower is the score, the better it is. So remember, lower the score, lesser is the mortality, and higher the score, more is the mortality, obviously, as you can well understand, right? And look at this MCQ now. July 2023, similar question was asked. 60-year-old man presented with acute onset right hemiparesis. So when you get question like this, don't panic. Similar question, break down the information and you will always reach the correct answer. So acute onset right sided weakness हुई. I told you, whenever you have acute onset neurological deficit which is asymmetrical, you should think of stroke in the patient, right? अब stroke कैसा हो सकता है? Hemorrhagic and ischemic, right? So इसमें क्या है? BP is 220/100. So first clue is hypertension present. NCCT is showing hemorrhage in the patient in the basal ganglia putamen region. So किस तरह का stroke हुआ है? It is a type of hemorrhagic stroke in the patient. So hemorrhagic stroke has happened, right? And so all should be done except BP control करना है, it has to be done. Cerebral edema management is a part of raised ICP management. Elective hyperventilation, yes, hyperventilation may sometimes be needed because raised ICP, you may sometimes require some hyperventilation so that carbon dioxide washout happens and raised ICP comes down. More about this I will discuss in a few minutes from now. What is contraindicated? Thrombolysis is contraindicated. Question is asking क्या नहीं करना है? What should not be done in the patient? Thrombolysis should not be done, and that is the answer. You can correlate with the management guidelines I just told you, right? Next question, December 2021, it was asked, 45-year-old man with a high HbA1c, diabetic patient. Emergency में he presented with acute onset hemiplegia, started 8 hours ago. NCCT showed intracerebral bleed and high BP was there. What is the best therapy? Now go systematically. Start RTP immediately will not be the answer because thrombolysis is contraindicated in cerebral bleed or hemorrhagic stroke. Sublingual nifedipine is not indicated anymore in any condition. Observation नहीं करेंगे, already stroke has happened. You have to do something. What you will do? BP control using IV labetalol will be recommended. Two different questions, 2 years apart. But if you see, if you who would have practiced one question, understood the meaning, the next question which came 2 years later, you would have been able to solve easily. The July question which I just showed you, the previous question, that was tough according to most students, but that was tough because you did not read the previous year questions properly, you did not read the previous year topics properly, and you did not revise them. If you just revise them, at least it makes sure that any direct indirect repetition makes it clear, because one-liners you will always be able to answer in the paper, right? So this is regarding the hemorrhagic stroke. Let's move further. And then we have the GCS score, the Glasgow Coma Scale score. It has been asked so many times in medicine and surgery, people still get it wrong. So at least read it twice before you sit in the exam, right? So GCS score, any patient who has neurological injury, trauma, any neurological illness, you need to check the consciousness, the status, mental status of the patient. So GCS score comprises 3 components. First of all, we have the eye opening, which is written as E, best verbal response, which is written as V, and the best motor response, which is written as M. So first of all, if the patient is opening eyes spontaneously, we give a score of 4. If there is a patient called Ram Prasad and Ram Prasad is has closed eyes, but when you say out Ram Prasad open the eyes, only on saying, on speech, he opens his eyes, give a score of 3. You say Ram Prasad open eyes, he doesn't open, but you give painful stimulus, then he opens, score of 2. And if he doesn't open at all, despite painful stimulus, score of 1. So remember that there is no zero score. It is a 4, 3, 2, 1 in the eye opening. Then verbal response, if it is oriented, appropriate response, verbal output score of 5. Confused patient score of 4. Inappropriate words score of 3. Shouting patient, using abusive language for no reason, score of 3. Incomprehensible sounds, some jargon words are being spoken, mumbling patient, you are unable to understand, score of 2. No response, no verbal output, score of 1. And best motor response, if the patient obeys commands and moves the limb, that is score of 6. Localizes to pain, score of 5. Withdraws from pain, score of 4. Abnormal flexion is score of 3. Abnormal extension is score of 2. And no response to pain, motor response to pain, is score of 1. And if there is a trauma patient, we have to categorize the patient. The trauma categorization is mild TBI is GCS between 13 to 15. TBI stands for traumatic brain injury. So if a patient has undergone traumatic brain injury, we calculate the total score. If the total score is 13 to 15, mild injury, 9 to 12, moderate injury, and 3 to 8 is severe injury. 2 points you need to understand here. In case patient is intubated, so you will not, obviously he will not be able to speak. So the verbal response word T should be used. So if the patient is intubated, it will be mentioned as, the V should be mentioned as T. T word will stand for tube in situ in the endotracheal region, right? So VT likhna hota hai, you don't write the number there. Another point on which MCQ has been asked, GCS low hoga to kya karenge? Any patient, any condition, due to any reason, GCS is less than 8, there is a high risk of aspiration, and always intubate the patient. So intubation is mandatory. You may need to sometimes do hyperventilation also if there is a raised intracranial pressure. So question आएगा आपको. You may get a question. There is a patient, road traffic accident, stroke, epilepsy, whatever reason, and GCS is less than 8. What is the immediate next step in management? Intubate the patient. Life saving. Not just here. Tomorrow, when you crack the exam, you join your internship. Think positively, you join your internship. Learn intubation. It's life saving. And tomorrow at midnight, a road traffic accident patient comes to you, GCS less than 8, nobody around. You intubate the patient. You are potentially saving someone's life. How to intubate is something you will learn during clinics. Not everything can and not everything should be learned virtually. There are things you need to learn on the bedside, and for that you need to crack your exam. So GCS score, these are the key points. Let's move further. Now scenario number 6. The scenario number 6 says that there is a child or adult who had dysentery 1 to 3 weeks back, right? So dysentery has happened about 1 to 3 weeks back in the patient. Secondly, they will say after dysentery there was acute ascending symmetrical flaccid paralysis. Symmetrical means both sides, and rising paralysis starts from the lower limbs and level increases, and flaccidity is there. Tone is gone, deep tendon reflexes are lost in the patient. CSF will show albuminocytological dissociation. What it means is that the protein level, the albumin level in CSF is raised, but there are no cells. So pleocytosis is not present. And bladder and bowel involvement is rare to absent. They are usually spared. So whenever there is a trigger factor, 1 to 3 weeks later, bilateral ascending paralysis, child or adult, the likely diagnosis in the patient is GBS. GBS stands for Guillain-Barré syndrome. Sometimes it is also written as Landry-Guillain-Barré syndrome. There is also a person known as Landry who described the disease also. So whether they say LGBS or they say Guillain-Barré syndrome, they are referring to the same entity. And some one-liners we need to summarize here. If they say Guillain-Barré syndrome has happened, what was the most common dysentery illness which can precipitate GBS? Not in all patients, but most commonly it has been found to be associated with Campylobacter jejuni. So Campylobacter jejuni dysentery is notorious for sometimes causing autoimmune response, autoantibody formation, which cause demyelination in the peripheral nerves. So what is GBS actually? GBS is a type of peripheral nerve demyelination disorder. So myelin sheaths jo hota hai, that gets destroyed. So it's a peripheral nerve demyelination disorder. Yes, there are varieties where axons can also be involved, but the common variety of GBS, we generally categorize it as a type of demyelinating disorder. Now about GBS, there are a few things we should know. What are the few things? First thing that we should know is about GBS, what are the subtypes of GBS? So the first subtype of GBS that we should remember is AIDP, and 90% cases are AIDP. So this is the first form, that is acute inflammatory demyelinating polyneuropathy. And these are the patients who are having anti-GM1 antibodies in about 40 to 50% patients. So anti-GM1 ganglioside antibodies are of IgG variety. So IgG anti-GM1 antibodies are responsible for AIDP. It's a FMG MCQ. Yaad kar lo. Just remember it. Second variety is acute motor axonal neuropathy, which is found in children and young adults. And these are the patients who have anti-GD1A antibodies. These varieties are also usually IgG. They can sometimes be IgM also. So GM1 is AIDP, the most common type. This is the most common type. AMN, acute motor axonal neuropathy में anti-GD1A antibodies है. Then we have AMSN, acute motor sensory axonal neuropathy. Mostly adults, it is a rare form, and it has overlapping features with AMN. And then fourth variety, Miller-Fisher syndrome, put a Q on top of it. Miller-Fisher syndrome can occur in any age. It's a atypical form. Miller-Fisher syndrome is characterized by a triad of three things. What is the triad? Ophthalmoplegia, ataxia, and areflexia. This is the classic triad. So I'm highlighting it here. Ophthalmoplegia, ataxia, and areflexia is the triad of Miller-Fisher syndrome. NEET PG one-liner question, it has been asked. And these are the patients who are having anti-GQ1B antibodies in 90% patients. So देखो, antibody type is varying. It is AIDP, it is anti-GM1, AMN, and sometimes AMSN, you have anti-GD1A, and Miller-Fisher syndrome, it is anti-GQ1B. If you have a look at the complicated tables given in your study resources, other types of antibodies can also happen, but examiner asks you black and white, and there in black and white you can easily mark according to this table. Very important table. All the points which are mentioned here, add them to your notes. Apart from this, if you have GBS patient, if you do a nerve conduction velocity, nerve conduction studies are written as NCS studies. NCS studies are considered to be very specific investigation. If you do nerve conduction study, what will you find? You will find that there are features of demyelination present in the patient. You will find that there will be reduced nerve conduction. The patient will show decreased nerve conduction, and there will be prolonged distal latencies. Prolonged distal latencies. I'm writing it because there is a MCQ on this. When you practice question, they will say there is a child who presented with illness followed by a neurological disorder where prolonged distal latencies were there. What was the likely diagnosis? The likely diagnosis will be Guillain-Barré syndrome. Now coming to therapy, treatment wise, treatment is very simple. The drug of choice in Guillain-Barré syndrome is IVIG, intravenous immunoglobulin. If IVIG is not possible, the alternative you can consider in the patient is plasma apheresis, also sometimes written as plasma exchange. Plasma exchange. Plasma exchange को PLEX भी लिखते हैं. PLEX is also written sometimes for plasma exchange in Harrison. And remember, MCQ point, there is no role of corticosteroids or prednisolone in the management of GBS. So I'm putting a Q on top of it. And if someone asks you, can the patient die? Yes, if the paralysis proceeds, doesn't respond, and you don't give therapy, most common cause of death in Guillain-Barré syndrome patient is respiratory muscle paralysis. Respiratory muscle palsy or paralysis is the cause of death in GBS. So in one table, one slide, I have covered a lot of queries, questions that you must revise before you sit in the exam. Moving further, we have scenario number 7. Scenario number 7 will say there is a middle-aged or young adult patient, more common in females or males, usually between 20 to 40 years. And they have paroxysmal. Paroxysmal means episodic paresthesias. Paresthesias क्या होते हैं? Altered sensations. Pin burning sensation in the limbs, pin prick sensation. Pain can also sometimes happen. So paroxysmal pain. Weakness of the body can happen. Visual loss can happen due to optic neuritis. Optic neuritis is a very important clue. So middle-aged female, sometimes middle-aged male, 20 to 40 year, optic neuritis, paresthesias, pain and weakness. and the patient question will say Lermit symptoms are present. Shock-like sensation. There will be a shock-like sensation starting behind the neck and going all the way from back to the lower limb. So Lermit symptom is another important clue to the question. And further they will say CSF showing oligoclonal bands. So these are the clues which are merging together. Keywords, they suggest that the patient is having a central demyelinating disorder. Guillain-Barré was peripheral. This is central demyelinating disorder called as multiple sclerosis. So multiple sclerosis, it is a type of central demyelinating disorder. What are the additional points that you should know? First thing, most common type of multiple sclerosis is a relapsing MS, also called as RMS, which is seen in 90% cases. Second thing, what is the hallmark? As I said, central demyelination is the hallmark in all of these patients. And how would you identify? When you do contrast MRI, you will find certain abnormalities to be present. The diagnostic criteria originally described for multiple sclerosis was called as McDonald's criteria. Old MCQ, McDonald's criteria used for what? M for M, multiple sclerosis is the answer. Don't mark myasthenia gravis, वो अलग होता है. Multiple sclerosis, McDonald's criteria, right? And if you do MRI, what will you find? You will find an abnormality called as Dawson's fingers. How would Dawson's fingers look like? Look at this picture. This picture has been asked in radiology. So when you do MRI, you will find these. Can you see these images? Let me just mark them. This one, this one, this one. So there will be focal plaques of demyelination which are present perpendicular to the lateral ventricle when you do MRI in the patient. So in the periventricular region, discrete areas, discrete patches or plaques of demyelination which are seen like this. This is called as Dawson's fingers, and this is the radiological diagnostic feature of multiple sclerosis, right? Now, multiple sclerosis, what is the therapy? Before I write the therapy, in case you are active on Instagram, I have also made a 1-minute reel which I had posted on my Insta personal account also, and also on my other where I keep putting clinical reels there. So I have put a 1-minute reel summarizing the therapy for MS there. But if you want to stay away from social media, good thing, no problem with that. In fact, you should be away from social media close to the exam. So summary you can listen here. So therapy for MS, it is based upon the latest Harrison. It says the agents used in MS can be divided into 3 categories: highly efficacious, moderately efficacious, and modestly, matlab doubtful efficacy. So first is highly effective. For highly effective, first of all, we have the anti-CD20 monoclonal antibodies. What are these? Rituximab, ocrelizumab, ofatumumab. Mushkil hai, I know, but understand that monoclonal antibodies are also asked in entrance exam, and you might get a pharma question. Which of the following is an anti-CD20 monoclonal antibody? All the 3 are anti-CD20 and they are highly effective in multiple sclerosis. Second, we have anti-integrin monoclonal antibody called as natalizumab. It's a past pharma question in the other entrance exams. So anti-integrin antibody. Third is anti-CD52 monoclonal antibody called as alemtuzumab, is highly effective. And then we have metoxantron hydrochloride, or simply metoxantron, which is highly effective. Then we have the agents which are moderately effective. It includes drugs called as S1P receptor modulator like fingolimod. If that is not in the option, you can mark cladribine and dimethyl fumarate are also considered to be moderately effective. And finally, we have modestly effective. It includes drugs like latremer acetate, interferon beta, and teriflunomide. In fact, latremer acetate was one of the earliest drugs which was used for multiple sclerosis, but now we know it is not always effective. It is the monoclonal antibodies which are now more effective therapies. In case you are running short on time and you cannot remember S1P receptor modulator or something, at least याद कर लो fingolimod. ऐसे और भी ड्रग्स होते हैं, सबके एंड में मॉड आएगा, तो ये जो मॉड वाले ड्रग्स हैं मॉडरेटली इफेक्टिव है, राइट? याद रहेगा, fingolimod, मॉड इज मॉडरेटली इफेक्टिव, नॉट मॉडेस्टली. मॉडेस्टली का मतलब मॉडरेट से कम है. So highly, as we go from here to here, the efficacy, the effectiveness tends to fall in the patient, right? Let's move further and talk about dementia. So the question arises, what is dementia? Dementia is a tough topic. I'll try to simplify as much as feasible in this last hour before the exam. So dementia, what is dementia? Dementia refers to acquired deterioration in the cognitive abilities that impair successful performance of daily living in the patient. So जब cognition, consciousness, intelligence abstract thinking of a person gets reduced, that condition is called as dementia. And there are multiple causes of dementia. The important causes of dementia, how to approach them and how to identify if you get a case scenario on this. Let us do a quick summary of that. So remember that all of them will be having some loss of episodic memory at some point in the natural history. So there is an approach to dementia that I want to discuss with you. So I will be making a handwritten flowchart here. Try to understand what I'm saying. So approach to dementia. First approach, dementia patient. If the question says it is a old age patient, usually above 50 to 60 year, old age patient, and the question says there is insidious. Insidious means gradually progressive, not acute or rapidly fulminant. Insidious, short-term memory loss has happened. Insidious, short-term memory loss which has happened over years. एक दिन में नहीं हुआ है, over years. Initially patient started forgetting a few things, then gradually it went on worsening over the years. Plus the patient is having anomic aphasia. I just discussed with you. Anomic aphasia किसमें दिखता था? Trauma, Alzheimer disease and metabolic encephalopathies, right? तो इनमें से कौन सा dementia है जो old age में है? Anomic aphasia है, Alzheimer disease. That is where we are going, right? Later on, as the disease progresses, the patient will develop apraxia. The patient will develop visuospatial deficits, and patient will become totally dependent upon others. That condition, the likely diagnosis in this patient is going to be Alzheimer's disease. So watch out for these keywords and you will always reach the correct answer. Alzheimer disease, potential one-liner, it is the most common primary dementia in adults. The most important risk factor is always old age. Most common primary dementia in adults, right? So Alzheimer disease. Second scenario, if the question says that there is a patient who has stroke history, there is a history of stroke in the patient. Secondly, the patient is having hypertension or atrial fibrillation, right? This is the risk factor. वहां पर था old age. Along with that, they would say that there is irregular dementia which shows stepwise progression. Stepwise progression. New symptoms appear, then they remain static for some time, then एक step आगे बढ़ता है, then they remain static for some time. That progression, stepwise progression, they will say, with a history of stroke, hypertension or atrial fibrillation in the patient, it is likely to be dementia due to vascular causes. We call it as vascular dementia. That is called as vascular dementia. I'm writing with a shorter, but trying to write as clean as possible so that I can fit everything in one slide. So vascular dementia. Vascular dementia is also, previously it was called as Binswager's disease. So Binswager's disease is the other name. And vascular dementia is the bracket, remember, overall most common cause of dementia in adults. It's a sequel of stroke or TIAs like episodes in the patient. Thirdly, if the question says that there is a patient who's having early personality changes. So personality changes, the patient presents with changes in the personality. What kind of personality changes? There is disinhibition. Disinhibition means patient cannot control his personality. The patient has excessive eating, and because of increased eating, he will have abnormal weight gain. Patient will develop apathy and loss of empathy. Apathy and loss of empathy means he will not be sympathetic to others, he will be lost and he will not take interest in the surrounding environment. So that personality changes along with dementia-like features, if they present, get an MRI done. And MRI will show the atrophy of frontal and temporal regions bilaterally. Frontal and temporal regions. The likely diagnosis, the likely cause of dementia in the patient is going to be frontotemporal dementia. frontotemporal dementia. If you have been a Hollywood fan and if you have watched Hollywood movies, Die Hard series, unfortunately, the great actor Bruce Willis has unfortunately been diagnosed with frontotemporal dementia, right? So Bruce Willis has been diagnosed and it has been publicly mentioned by the concerned medical team and the profession also. So may the guy survive and come out of it. So frontotemporal dementia. If the examiner is fond of Hollywood movies, he's a Bruce Willis fan, he wants to put a question on dementia, he might put it on this. So they will frame it like features of dementia along with personality changes and MRI showing atrophy of frontal and temporal regions. So that is frontotemporal dementia. And fourthly, if the question says that there is a child or there is a not a child, sorry, there is a patient who's having dementia along with visual hallucinations. If the question says there is a patient who's having visual hallucinations, Parkinson disease like features, and there are abnormalities in the rapid eye movement sleep. So REM sleep disorders will be there. So these patients are likely to have what kind of cause of dementia? It is going to be DLB. What is DLB? DLB stands for dementia with Lewy bodies. Previously it was called as Lewy body dementia. So dementia with Lewy body or Lewy body dementia, this will be the presentation. And I hope you know there was another Hollywood actor, Robin Williams. So Robin Williams was posthumously diagnosed with dementia with Lewy bodies, right? So these dementias are all around us. They occur in the resource limited areas also, but unfortunately they are not diagnosed. In the Western world, they come to diagnosis much easier. Apart from that, there are other causes of dementia also. For example, there is a prion disease, Creutzfeldt-Jakob disease, which can cause dementia, but they will have clue in the form of, so you can write, if the question says that there is a patient who's having a dementia-like illness, along with myoclonus or myoclonic jerks, that is abnormal body movement which are shock-like, along with mood and anxiety disorders, and no other cause can be found, you should suspect it is likely. Myoclonus is an important clue, likely diagnosis in the patient, and myoclonus occurs early in the course of the illness. It is likely to be prion disease. What prion disease? Creutzfeldt-Jakob disease is the likely diagnosis. I know it's a bit boring, but I wanted you to write and explain, because all the words which I've mentioned here, they are taken from standard books, and if you practice past questions, they are clues hidden in the question statement. Diagnosis tabhi banega only when you read it. See, you may or may not get a question from this, but if you get a question, trust me, it is going to be a tough question. And tough question, you mark it correct. There is some random one-liner which you marked wrongly or silly mistake that will be covered through that question, right? So approach to dementia, this is what you need to remember. So let us move further and talk about Alzheimer's disease. I will not waste any time. Some months back, I had shared one summary of Alzheimer's disease. Because time is running short, so I will not go into the details. This file obviously you will be getting. It is there on my social media page, and this is the Instagram page where I put only academic updates, no personal details or collaborations or anything. So you can just have a look at here. So how will the MRI look like? What are the genetic risk factors? What are the other risk factors? How progression happens? What are the FDA approved therapies? Everything I've mentioned it here. Has it been asked in details in the entrance exam? The answer is no, but can it be asked? The answer is yes. So you should be at least ready for it. Two one-liners I want to emphasize here. What type of deposition of amyloid happens in dementia? So if the question says patient with Alzheimer's disease, what kind of amyloid gets deposited in the brain? It is A beta amyloid deposition. So A beta amyloid deposits in the brain, right? And if the question says patient with dialysis related dementia, dialysis related dementia is a rare form of dementia which occurs in chronic renal failure patients. So in these patients you have A beta 2 microglobulin which is deposited, and there are MCQs on this, MCQs on this. So A beta here and A beta 2 microglobulin here. It's a recent question also, dialysis dementia. Let's move further. And then we have the scenario number 8. This scenario number 8 is extremely important. Two MCQs, case scenarios on this have been asked in the past. So scenario number 8 would say that there is an adult patient, any gender. The patient will have diplopia, double vision, ptosis. Ptosis means drooping of the eyelid, snarling expression on chewing. Now what is snarling expression? Snarling expression, it is described as when you're very angry, very animated, your nostrils are flaring and your upper lip is, going backwards and getting prominent. So I know I'm going to look bad doing this, but snarling is something like this. Look at me. My nostrils are flaring and my lips are going like this. This kind of expression where the upper lips are going back and nostrils are flaring. Some of the angry young men heroes, they tend to do in the movies. So snarling expression on chewing will be present in the patient, and then they will have fluctuating proximal muscle weakness. So proximal muscles, the hip girdle and shoulder girdle muscles will show fluctuation. When you exercise, the muscle strength will fall. When you rest, muscle strength will improve. Muscle strength will also improve on giving a drug called as myostatin. If you have a scenario like this, the likely diagnosis is myasthenia gravis. Myasthenia gravis, many celebrities have been diagnosed with myasthenia gravis as opposed to the dementias. It is not a dementia and it is a condition with which you can live a relatively normal lifespan. Myasthenia gravis is a type of neuromuscular junction defect. Due to autoimmune causes, there is formation of antibodies which destroy the receptor for acetylcholine in the patient. What are the key points you should know? So additional points, first of all, majority of them are having some degree of thymic abnormality. Most commonly you see hyperplasia of the thymus. Some patients can have thymic tumors called as thymomas as well. Then antibodies are found. These antibodies, the most common type of antibodies are anti-acetylcholine receptor antibodies. You can also have anti-MuSK antibodies followed by anti-LRP4, and anti-agrin antibodies have also been described. Then we have repetitive nerve stimulation test can be done, and adrophonium test produces muscle strength improvement. That is also a clue for myasthenia gravis. And what is the therapy? Pyridostigmine, which is a acetylcholinesterase inhibitor, that is considered to be the drug of choice. Steroids can also be used, and thymectomy is done in refractory cases, particularly where thymomas are found. There is a similar syndrome, which is a paraneoplastic syndrome, which resembles myasthenia gravis but is different from that, called as Lambert-Eaton myasthenic syndrome. LEMS usually occurs as a paraneoplastic syndrome. There is a variety called as oat cell carcinoma of the lung where LEMS happens, and these are the patients where a drug called as 3,4-aminopyridine or 3,4-aminopyridine derivatives are useful in the management. But it is not the same syndrome as myasthenia gravis, and it is very rarely described, right? So for all practical purpose, what is asked in the exam is myasthenia gravis. Now moving further, we have abnormal body movements. Before we discuss the cases, understanding how to identify what is being talked in the question, you need to know what are the abnormal body movement. So I'm making a handmade chart here. So if there is a person, there is a patient having abnormal body movement, you have to see whether it is a rhythmic movement, किसी rhythm के साथ हो रहा है, या it is a non-rhythmic movement. Examiner will say, and you will get the clue कि what is the type of body movement. देखो अगर तो वो बोल देगा dystonia है, tic है, chorea है, then तो you know. Sometimes they will not say chorea है या क्या है. They will simply say rhythmic body movement or a non-rhythmic body movement. So remember, if there are rhythmic body movements, also called as rhythmic oscillations, that is what you call as tremors. Tremors can have multiple causes. We will come to that. On the other hand, if it is a non-rhythmic cause, so there can be multiple types. If it is a non-rhythmic body movement, which is slow, writhing kind of movement, slow writhing movements, but non-rhythmic, no rhythm is there, we call it as acidosis. If the question says that there is a non-rhythmic movement, but in the form of sustained muscle contraction, sometimes it can cause pain also due to sustained muscle contraction. That is what you call as dystonia in the patient. Dystonia. Thirdly, if the question says rapid non-rhythmic movements are there, so there are two possibilities. क्या वो suppress हो सकते हैं या नहीं हो सकते? If the rapid movement is suppressible, you can voluntarily stop the movement if you try to focus, then you will call them as tics. So tics are always suppressible. And if the question says they are non-suppressible, non-suppressible. They are involuntary. You cannot control them. So non-suppressible if they involve the distal muscles. That is hands and feet में होंगे, fingers and hands में होंगे. So distal muscles, it is likely to be chorea. If they involve the proximal muscles and they are very dramatic, violent movements, proximal muscle violent movement, they are called as hemibellismus. Hemibellismus. And if the MCQ says that they are shock-like, electric shock-like jerks, then you will use the word myoclonus for them. They are seizure-like episodes, shock-like jerks which will happen, right? So chorea जो होता है usually hands के अंदर देखा जाता है. Remember this. So based upon how the case has been framed, you will be able to understand what is being talked about in the question. Let us have a look at some case scenarios. So scenario number 9, very important scenario. So question will say adult patient hai who's having a mask-like expressionless face. Secondly, they will say that the patient is having rigidity, tremors which are present at rest, and bradykinesia. So movement is restricted. If I don't go further, अभी तक आपको पता चल चुका है, these are the cardinal features of Parkinson disease, right? Let us go further. Unstable posture is there, reduced blinking and drooling of saliva, and some patients will have autonomic disturbances like genitourinary problems, sweating related problems, BP fluctuations. Some of them can have GIT problems like constipation and diarrhea, so autonomic disturbances. And shuffling gait will also be found in the patient, right? So shuffling gait. So if all of them or any combination of these are mentioned in the question, tremors at rest, rhythmic movements, the likely diagnosis is Parkinson's disease, right? Now regarding Parkinson's disease, it is a basal ganglia dopamine defect. The dopamine production is reduced, or there are some rare forms where the dopamine is, the neurons become insensitive to dopamine. So Parkinson's disease occurs due to deficiency of dopamine pathway in the basal ganglia. Now regarding Parkinson's disease, there are some points we need to remember. First of all, what is the pathological hallmark? There is degeneration of dopamine producing neurons, dopaminergic neurons in the substantia nigra pars compacta. This is the location, potential MCQ point where the disease manifests. Second, alphas, sometimes, not always, but sometimes Parkinson's disease can be genetic, and the genetic forms, the most common gene mutation which has been described is alpha-synuclein gene mutation, also called as SNCA gene mutation. Treatment is levodopa or dopamine agonists like ropinirole and pramipexole, and along with levodopa we sometimes add COMT inhibitors. They reduce the side effect and increase the duration of action, and other types of drugs have also been described. So pharmacology part you have already done. So fine details are not usually asked in FMG exam, but you must do them at least from the pharma part as well. So these are the additional points regarding Parkinson's disease. And then we have this scenario which was recently asked, and many of you messaged me saying, sir, इस topic के बारे में बोल दो. So I was intended to take it up, but here I am discussing it here. As all of you, some of you asked. So this scenario, recent FMG paper, it has been asked. So question would say, adult patient between 50 to 60 years, involuntary jerky hand movements, right? Jerky hand movements are not likely to be tremor. और क्योंकि tremor नहीं, वो rhythmic होता है, या word tremor will be used. तो अगर involuntary jerky hand movements हैं, तो non-tremor like situation है. And the patient is having progressive loss of cognition and behavioral issues, and the question sometimes can say atrophy of the caudate nucleus. Jerky hand movements can either be myoclonus, but myoclonus will be a part of some other illness, either a shock-like sensation, either a epileptic condition, or it will be a part of some Creutzfeldt-Jakob disease like dementia disorder. So involuntary jerky hand movement likely to be chorea. Chorea movements are very common among the involuntary movements. So jerky movement, loss of cognition and behavioral issues, likely diagnosis is Huntington's disease. Remember, many people when the question came got confused कि sir Parkinsonism क्यों नहीं है? No rigidity, no tremor, no mask-like face, no shuffling gait, no tremors at rest. right? Tremors at rest are not there, and that is why it is Huntington's disease. Huntington's disease is a trinucleotide repeat defect. So let us do a quick summary of Huntington's disease. Additional points. What is the cause? More than 40 CAG repeats. So more than 40 repeats occurring in the Huntington gene present on short arm of chromosome 4. And these CAG codes for polyglutamine. So glutamine, more than 40 repeats are responsible. And then neurotransmitter status. Dopamine transmission is increased. So it is opposite of Parkinsonism. Increased glutamate, which is excitatory, reduction in the inhibitory neurotransmitter called as GABA. And treatment of these patients, drug of choice is tetrabenazine, but tetrabenazine side effect, it has anti-dopaminergic action, and so it can cause drug-induced Parkinsonism in some of the patients. Unfortunately, prognosis in Huntington's disease is not great, and majority of them progress and they become vegetative or they die due to multiple complications. So this is a patient with Huntington's disease. Now the next thing is raised intracranial pressure. So what I'm going to discuss here is the applied part which is asked in the exam. First of all, how would you know that the patient is having a raised intracranial pressure? What are the clues the examiner will say that you will look out for in the question? If there is a patient with raised intracranial pressure, he may or may not have any history of trauma or any acute illness in the patient, right? Sometimes the presentation is in the form of raised ICP. Sometimes you are just sitting in an emergency room and the patient is brought in. What are the things you will look out for in the question or in the case scenario which will tell you that it is raised ICP? Patients who are having raised ICP, first of all, they will be having headache. Headache in raised ICP has a particularly important characteristic that headache is more in the morning hours. So early morning headache, and it is often accompanied with, it is associated with projectile vomiting. Headache associated with projectile vomiting is one clue or one manifestation of raised intracranial pressure in the patient. Secondly, the patient may have altered sensorium. Altered sensorium. His sensorium will be low. He may not be oriented to time, place and person. So altered sensation, altered sensorium will be present. Thirdly, the patient may be having what you call as Cushing's triad. Now Cushing's triad, as a separate one-liner MCQ, it has already been asked. What is Cushing's triad? Whenever there is raised intracranial pressure, the patient will be having hypertension along with bradycardia, along with respiratory depression, apnea or irregular respiration. So respiratory abnormalities will be there. Irregular respiration. This is called as the so-called Cushing's triad of raised intracranial pressure. Sometimes some patients, not all, may present with, sometimes they may present with cranial nerve palsies. And cranial nerve palsy, which is frequently involved, is sixth cranial nerve. Because it is not a localizing sign, so it is also sometimes called as a false localizing sign. False localizing sign. And then there can be other features also mentioned. If you look at Google or if you try to read a textbook, you will find a lot of things mentioned. One particular important thing is fundus examination. And fundus examination in the patient will show papilledema. In fact, if they just mention papilledema along with any of the features which I mentioned above, we assume and manage according to raised intracranial pressure. So fundus will show papilledema. Papilledema means swelling of optic disc. Whenever there will be raised intracranial pressure, it will be transmitted to the optic nerve head. When you do fundus, there will be blurring of the disc margin, and that is called as papilledema. So fundus will show papilledema. In case the patient presents with advanced raised ICP, what are the bad signs of raised ICP? Bad signs means they are also called as ominous signs. They are also called as advanced raised ICP. So bad sign क्या होंगे? First of all, there will be pupillary abnormalities. So the pupil जो होते हैं eyes के, when you check for the light reflex, they will become sluggish, they may become fixed, they may become unequal. So pupillary abnormalities. Secondly, patient will develop upper motor neuron signs. I hope you remember what are upper motor neuron and what are lower motor neuron signs. Upper motor neuron signs, example, there will be brisk or exaggerated deep tendon reflexes. and Babinski sign may be positive in the patient. And then patient may sometimes show posturing. Posturing is one area where urgent management of raised ICP needs to be done. Otherwise, herniation of the brainstem will happen and patient can die. Posturing can be of two types, decorticate or decerebrate posturing. So these abnormalities are the ones which require that you manage the patient in a urgent setting, right? So this is in general which I'm talking about. Obviously the topic is more complex than this. So these are the clues the examiner will say that which will raise the suspicion that it is raised ICP in the patient. Now how you are going to manage in the patient? So management of raised ICP I will be doing again as a summary form. First of all, you should know the general goals. According to Harrison, you should target that the intracranial pressure in the adult remains less than 20 and CPP refers to cerebral perfusion pressure is equal to or more than 60 millimeters of mercury, right? This is the target that we set for. And in case the patient presents with ICP more than 20 to 25 for more than 5 minutes, what steps you will be taking? Many times if you have a facility to place a intracranial pressure catheter, it should be catheter driven. But you know, in an Indian setting, in a resource limited setting, it will not always be possible. So any sign and symptom of raised ICP, how you are going to manage? Patient presents to you in emergency. First of all, you will do the airway, breathing, circulation measurement and manage it. Along with that, you will also check for GCS. Why you are checking for GCS? I told you the funda that any patient, if the Glasgow coma scale is less than 8, immediately intubate the patient and then do the further management. If GCS is more than 8, then you can take a call whether to intubate or not. So it will be a clinical call. So ABC karna hai, airway, breathing, circulation and Glasgow coma scale should be assessed. Then you will do the investigation part that will be done. For the raised ICP management, you will first of all perform the general measures. So two parts therapy you can divide it into. First are the general measures. So general measure bhi aapne saath mein hi start karne hai. So general measures should be started simultaneously. What are the general measures? Elevate the head end of the bed. Elevate the head end of the bed to about 30 degrees. If they ask you a range, it will be 15 to 30 degrees. It allows postural drainage of the venous flow and it helps to reduce the raised intracranial pressure somewhat. You should avoid any painful stimulus. It is also sometimes written as noxious stimuli. So any sampling, unless absolutely essential, it should be avoided. And if you should treat fever if present. And also you should avoid unnecessary suction in the patient. Because when you do suctioning of the endotracheal tube repeatedly, that can also cause raised intracranial pressure. And blood glucose should be maintained within normal limits and all these ABG should be done. So all these things you will do. Like obviously when you do ABG, some pinprick will be there, but that is needed. But apart from that, unnecessary pricking just for routine purposes should be avoided. Apart from that, you will be doing specific management in the patient. And among specific management, in most of these patients, the first line therapy is always osmotherapy, also called as osmotic agents. So what are the osmotherapy? What are the two agents approved for use? You can either go in for IV mannitol. IV mannitol can be given. The dose in children, it is per kg body weight, but in adults the dose is very clear. Harrison says it is between 25 to 100 grams given IV every 4 hourly. So IV mannitol will be given, or you can consider IV hypertonic saline. Through osmotic mechanism, they tend to produce diuresis and they tend to reduce the raised intracranial pressure in the patient. IV mannitol, you should remember that it is avoided. It is avoided in patients who are having renal failure. So if there is already an acute kidney injury patient, you should be avoiding mannitol. If there is a raised ICP with shock, sometimes shock can be there. So again, mannitol will cause fall in the BP, so it should be avoided. In these patients, hypertonic saline will be the safer agent. And you should, whenever you are doing osmotherapy, you should make sure that the osmolality of the blood does not change too rapidly or too much, right? So this is the osmotherapy. After osmotherapy, what are the other agents that you will consider? What are the other therapies that you will consider? First of all, what is the role of steroids? Steroids like dexamethasone. Steroids like dexamethasone should be started only if there is vasogenic edema. Vasogenic edema due to ICSOL. What is the ICSOL? ICSOL stands for intracranial space occupying lesion. Intracranial space occupying lesion. Can you give an example? Can you think of an example? For example, patient having a localized cyst, patient having a tumor, patient having a localized abscess. If due to mass effect there is vasogenic edema happening, then you will give it. But idiopathic or traumatic brain injury patient with a diffuse edema or no space occupying lesion found, steroids will not be needed. So what is the indication for using steroids? In case there is a vasogenic edema due to ICSOL. Harrison very clearly says that steroids should be avoided. Steroids should be avoided in patients who are having, first of all, if the patient is having a ischemic stroke. If there is ischemic stroke and that is causing raised ICP, you should avoid it. Secondly, if the patient is having intracranial hemorrhage, for example, the hemorrhagic stroke which has happened. And thirdly, in case there is head trauma. These three conditions you should avoid using corticosteroids. And apart from that, you can consider hyperventilation. Hyperventilation will cause washing out of the carbon dioxide and it will reduce the intracranial pressure. But hyperventilation is a short gap arrangement. It is used only if impending herniation is present. If you feel that unequal pupils are there, posturing is there, and the other agents are not being effective, so till you do the second line therapy, then as a short-term measure you can go for hyperventilation. Otherwise, hyperventilation per se does not have a long-term effect. And you can consider, in case the patient is having a low BP, in case there is a low BP, you can also consider agents like phenylephrine. Phenylephrine, in case you find that there is a shock patient with low MAP. What is MAP? MAP stands for mean arterial pressure, because that is going to affect the cerebral perfusion pressure. You should always target that the cerebral perfusion pressure I mentioned here also, it should be equal to or more than 60 millimeters of mercury. And still, if the patient is not improving, you will take up the patient for second line agents. What are the second line agents you can consider? Second line agents will include planar neurosurgery, urgent neurosurgery. You can go for decompressive craniectomy. You can go for pentobarbital coma. Using obviously all these patients will be intubated and they need to be managed in a ICU, and you can do controlled hypothermia up to a temperature of 33 degrees Celsius. Although clinically used, but Harrison, as well as what I have seen in my clinical practice, diuretics are not used commonly in the management of raised ICP. So osmotherapy followed by considering steroids but avoiding in certain scenarios, considering hyperventilation, considering phenylephrine, doing the general measures, followed by second line therapy. This entire discussion, there are other drugs also which we use clinically, but this entire discussion is based upon the table given in Harrison. And that is the, as I said before, the most important thing you need to remember for the exam, right? So I hope you benefit from this table which I discussed here. Let us move further. So next, now we are going to take up some epilepsy scenarios, right? So we can increase the speed now. So epilepsy scenario, first scenario, MCQ examiner will say that there is an infant with developmental delay. So child less than 1 year having developmental delay. There is a jerky flexion of neck and limbs like this, which is called as salam spell. So highlight the keyword salam spell. Salam spells is a flexion episode where the the arms as well as the neck falls forward and the hands come in the midline, producing a jerk like this. So the child gets up from sleep and starts doing like this. These spells tend to occur in clusters. Clusters means in a very short span of time, a lot of these spells will happen. And thirdly, EEG will show a specific chaotic brain activity, chaotic rhythm, known as hypsarrhythmia. So if a combination of this picture is given to you in the exam, the likely diagnosis in the patient is going to be West syndrome, right? So let us do a brief summary of West syndrome. West syndrome, first of all, what is 40% cases of West syndrome, they occur due to CNS insult. CNS insult means there is a damage to the CNS due to some reason. Remaining cases, about 50% cases, no cause is found. So they are called as idiopathic or cryptogenic West syndrome, and less than 10% cases are found to be syndromic. If they ask you what is the syndrome associated with West syndrome is also a part of another syndrome. So you can remember there is a neurocutaneous syndrome called as tuberous sclerosis. And tuberous sclerosis, TSC, it should be suspected if there is a hypopigmented skin macule. Question bolega, there is a patient having hypopigmented skin lesion along with CNS deformities, along with CNS tumors, which are usually benign tumors, along with West syndrome. So in these patients, you will consider tuberous sclerosis to be present. So if they ask you कि कौन सा syndrome में West syndrome can happen, it is tuberous sclerosis. But remember that vast majority of West syndrome is not associated with tuberous sclerosis. It is either due to CNS damage or it is due to idiopathic or cryptogenic causes. Now, regarding West syndrome, there is a triad you need to remember. What is the triad of West syndrome? Triad has been asked in the exam. So three things will happen. There will be epileptic spasms. These epileptic spasms, known as salam spells, are also called as infantile spasms. So infantile spasm and West syndrome are synonymously used. Secondly, there will be low IQ if it is an older child. If it is a younger child, there will be developmental delay. So CNS abnormality will be there, and EEG will show presence of hypsarrhythmia in the patient. Outcome is very bad. If the seizures are controlled, mild mental retardation or intellectual disability. If they are severely controlled, severe intellectual disability will happen in the patient. So what is the treatment of West syndrome? Treatment has been asked 2 times in the past papers of FMG exam. So the drug of choice in West syndrome is always high dose ACTH. You can get stuck up, like in one of the exams in INI-CET, people got stuck up in high dose dena ya low dose dena. High dose ACTH should be given. If that is not in the option, you can go for vigabatrin. But if the question says there is a patient with tuberous sclerosis, so drug of choice in tuberous sclerosis wala West syndrome, here vigabatrin is more effective, followed by ACTH. Right? So this is a quick summary how you're going to identify and what is the likely diagnosis. Let us have a look at another scenario. Question will say female child aged 3 to 10 years, vacant staring look lasting few seconds. बच्चा खो जाता है, there is no blinking and the patient stares vacantly for some time. Decline in the school performance has happened, so school grades are falling and aggravated or precipitated by hyperventilation. What is hyperventilation? देखो एक होता है rapid breathing, fast breathing. What is fast breathing? Where the rate is increased. इसे कहते हैं rapid breathing, right? What is hyperventilation? Where the rate and depth both are increased. For example, somebody breathing like this. Can you see the rate and depth both are increased? That is hyperventilation. So hyperventilation, not in you and me, but in a patient with a predisposition, it will trigger a seizure. So if they say female child, can occur in males, but more common in female, age 3 to 10 years, it is the age during which these patients present, although it can occur in adults also. It can continue into adulthood. It continues lifetime, but starts between 3 to 10 years and vacant staring look lasting few seconds. No developmental delay, but school grades will start falling because the child is unable to focus. That is what you call as epilepsy, called as absence seizures. Other name of absence seizure, it is also known as petit mal epilepsy. There are no motor movements in the usual variety, the typical absence seizures, and if there is a motor movement, myoclonus or loss of tone, we call it as atypical absence seizure. Regarding absence seizure, what is the investigation of choice? You always go in for EEG, and EEG will show a pattern known as 3 Hertz spike and slow wave pattern. 3 Hertz spike and slow wave pattern. 3 Hertz means 3 waves in 1 second. If you look at a 1 second interval, there will be a spike and there will be a slow wave. Spike and slow wave, spike and slow wave. Don't confuse it for ECG. This is a EEG. It is a stupid way to show it, But this is what they mean. There is a spike and there is a slow wave which is happening. ऐसा नहीं होता है, but there is a stupid way. If you try to zoom in and try to see some of the patients with absence seizure in some of the leads, EEG, in the brain leads, they will show a pattern like this. So teen waves or teen spikes are coming, so we call it as absence seizure in the patient. And what is the therapy to be given in absence seizure? In absence seizure, the drug of choice is, now drug of choice is controversial. Age-related funda, which is mentioned in pharmacology textbooks, clinically we do not follow it. So drug of choice, we always use the word ethosuximide is considered to be the most effective drug. Ethosuximide is the most effective drug. However, if they say which is the drug which is commonly used in my clinical practice, what drug I use commonly, it is valproate. It is the most commonly used, and both of them are considered to be the first line agents, and no serious textbooks chooses one over the other. And you would be surprised to know, examiner, when the question came in FMG exam, they did not put ethosuximide there. So it was easy, case scenario was there, you had to pick valproate. Yes, there is a funda, there is a saying that below certain 3 years you should be using this, and above 3 years. See, you need to understand that below 3 years, anyways, absence seizure is not very common, right? And young children, we tend to avoid using valproate because valproate can cause hepatotoxicity in the patient. That is the rationale here. Having said that, that pharma rule is not clinically applied in most of the settings. And most of the current guidelines, including AOCN guidelines, which we follow in pediatrics as well as in neurology clinics, they say that either of the two drugs can be used. The reason we don't use ethosuximide is not because of availability, it is available. Ethosuximide can worsen other epilepsies if they are present along with this. And that is why valproate is a safer drug to use, right? If they say drug of choice in atypical absence seizure, atypical means patient is having motor component or there is a loss of tone. फिर तो answer is very clear, you will go in for valproate only. Ethosuximide is not much effective in these patients, right? So this is the second scenario. Moving to some miscellaneous one-liners and clues. So drug of choice in status epilepticus, whether it is a child or an adult, the drug of choice are always IV benzodiazepines. And if they ask you which is the best IV benzodiazepine to use, IV lorazepam is the drug of choice. IV lorazepam, maximum how many doses can be given? Up to 2 doses of lorazepam can be given 5 minutes apart, right? And if benzodiazepines are not effective, then obviously we go for the next line agents. The next line agents include phenytoin or valproate or levetiracetam. Either of these can be used. Phenobarbital is preferred only in newborns, not in children and adults. So adult में phenobarbital you have to avoid, right? At least in the management of status epilepticus. Now, if they say what is the drug of choice in Rolandic epilepsy? Rolandic epilepsy is an epilepsy which is self-limited, good outcome, starts around 2 years and finishes around 12 to 13 years. But it can cause problems in the child, and so the drug of choice in these patients are carbamazepine. It's a pediatric self-limited epilepsy, and carbamazepine, if that is not in the option, you can go in for oxcarbazepine. Third scenario, third one-liner, drug of choice in neonatal seizure. This is a past FMG question. It is phenobarbital. Phenobarbital is the drug of choice in newborn seizures. Then focal seizure. There is a case scenario asked on this. All of them are actually MCQs in one way or the other. So question will say there is a patient, child or adult, who presented with focal seizure, right? And the CT scan was showing multiple REL. What is REL? Ring enhancing lesions. तो आप CT करेंगे, ring enhancing lesions will be present, and some of them will be showing a scolex in between. So if you have multiple ring enhancing lesion, focal seizure with a scolex, it is likely to be NCC. What is NCC? The likely diagnosis is neurocysticercosis. Neurocysticercosis is caused by the Taenia species. It can cause scolex formation that can irritate the brain parenchyma, and it can cause seizures as well as raised ICP and focal neurological deficits. Remember the funda in neurocysticercosis. Does the pathogen, does the parasite die by giving albendazole? Yes. But should we start albendazole directly? No. Any patient who is diagnosed with neurocysticercosis, First start the patient on prednisolone. After few days, then we start the patient on antihelminthic agent. What is antihelminthic agent? Albendazole is the therapy that we give. If albendazole is not there, you can go for praziquantel as well. So funda kyun hai? Why are we giving this? There is a very important clue, and there is also a case scenario MCQ on this. If you give in an active neurocystic psychosis patient, if you give albendazole, the pathogen, the parasite will die, and that will elicit inflammatory reaction which can cause raised ICP, brain edema, and can worsen the patient. तो पहले हम क्या करते हैं? We give a cover of steroid to decrease the edema around the cyst. Remember, it is a space occupying lesion. मैंने पढ़ाया था steroids to be given, raised ICP, vasogenic edema. तो उसके बाद after patient is stable, then we give albendazole, right? Now, what dose to be given? Albendazole alone or albendazole with praziquantel? So there are case scenarios depending upon what stage of NCC and how many cysts are present. That is something examiner is unlikely to go into detail. You read it when you prepare for the NEET PG or INICET exam later on, right? So neurocystic sarcosis, this is the funda. And remember, if there is a starry sky pattern, kabhi-kabhi kya hoga, when you do CT scan, starry sky pattern will be there. Hundreds of NCCs will be there. In these patients, we don't even give albendazole because that is going to cause dying of these cysts, and that is going to elicit an inflammatory reaction. And lastly, if someone asks you calcified cyst hai, so calcified cyst again you will not give because already calcification, the parasite has died. Only give prednisolone, and in case patients is having seizure, for seizures you can use either carbamazepine, oxcarbazepine, lamotrigine, any of these agents can be given. Right? So this is what I wanted to emphasize here. Moving further, miscellaneous one-liners and clues. When will you suspect meningitis? Whether it is a child or adult, question will use some common themes. They will say fever, they will say headache, patient will be having vomiting, patient will be having photophobia, intolerance to bright light, or intolerance to ambient light, not bright, and they will be having nuchal rigidity, that is neck rigidity, and other signs which are signs of meningeal irritation like Kernig sign as well as Brudzinski sign. If you have a combination of features mentioned like this, the likely diagnosis in the question is going to be meningitis. So watch out for these clues. Secondly, if you do CSF and CSF shows raised cells which are neutrophil, raised protein, low glucose, तो क्या suspect करेंगे? You will suspect bacterial meningitis in the patient. So acute bacterial meningitis or pyogenic meningitis should be suspected in the patient. In case the CSF is showing lymphocytes with raised protein and low glucose, you will suspect tubercular meningitis in the patient. So watch out for the clues. There are questions, past examiner questions which are there. I have also discussed approach to CSF findings. There is a detailed, slightly more detailed discussion I have done on YouTube. It's on the YouTube channel of Doc Tutorials. For those who have not seen that pediatric discussion, please have a look at it, because end of the day pediatrics is also important, and you know that those who have given the last exam or your seniors might have told you 15 to 18 questions are asked from pediatrics. Yes, medicine is maximum, but pediatrics also is a very scoring area, and in the last 3 papers of FMG, 5 questions on meningitis have been asked, and all of them were pediatric questions, not adult questions, although things will remain virtually the same except for organism and slight doses and management guidelines. So if you have to make the diagnosis, just go through that video once. So raised cell, lymphocyte, raised protein, low glucose, TB meningitis. If the question says CSF showing raised cell, lymphocytes, raised protein but normal glucose, so it is likely to be aseptic meningitis. Aseptic meningitis is usually caused by viruses, so we call it as aseptic or viral meningitis in the patient, right? Now, what is molar-rate meningitis? It is a type of aseptic meningitis which is caused by herpes simplex virus 2. So HSV2 meningitis is called as molar-rate meningitis. It's a one-liner past question. Then what? HSV encephalitis, brain parenchyma involvement. If there is meningoencephalitis or HSV encephalitis, what is the important clue? Examiner will have examiner will say the patient has focal neurological deficits, because brain parenchyma is getting involved. He will have seizures, he will have fever with or without meningeal signs. So signs of meningeal irritation may or may not be present, and the type of seizures are always focal seizures. And what part of brain is involved? HSV encephalitis has a special tendency to produce temporal lobe involvement. Very, very important. If the question says CT scan kiya and you found bilateral temporal lobe involvement or bilateral frontal and temporal lobe involvement, which encephalitis should be suspected? HSV encephalitis is likely to be the answer. So acyclovir you will start. So clues hain, ye clues hain which at the last minute before the exam you can't read everything. So these are the clues, you will have a better chance of marking the answer correct even if you have forgotten the topic. If the question talks about Japanese encephalitis virus encephalitis, they have a specific tendency to cause bilateral basal ganglia involvement. तो अगर बोलें any encephalitis patient with bilateral basal ganglia involvement, you will think of Japanese encephalitis virus as the answer, right? So moving further, patient question, case scenario, patient having normal deep tendon reflexes लेकिन muscle weakness present and muscle weakness varies according to the time of the day. The likely diagnosis we have already discussed, myasthenia gravis. Because the problem is not in the nerves, it is in the neuromuscular junction. Then reversible dementia, it is usually seen due to nutritional causes. Nutritional causes, it's a recent MCQ asked in FMGE exam. Nutritional causes like vitamin B1 deficiency, dry beriberi can cause it. It can also occur due to vitamin B3 deficiency, niacin, pellagra, diarrhea, dementia, dermatitis. Remember that is a reversible dementia. And thirdly, it can happen due to B12 deficiency. It can involve spinal cord. It can affect the posterior parts of the, rarely, sometimes it can involve the temporal and occipital lobes also. So reversible dementia caused by nutrition causes, B1, B3, B12. Then dementia with myoclonic jerks. If the question says, what will you suspect? This is something I've already discussed with you. Prions disease. अभी किया था ना हमने Prions disease. So the likely diagnosis will be Prions disease. Prions are infectious particles, proteinaceous infectious particles devoid of any nucleic acid. So the question, one of the option in the exam, the question which had come was variant Creutzfeldt-Jakob disease. So variant CJD or Prion disease will be the answer. If the question says prosopagnosia, prosopagnosia will be inability to identify familiar faces or familiar objects. That is called as prosopagnosia. There is a question on this. Then pendular knee jerk. अगर question में mention कर दे along with ataxia, along with other features, always think of cerebellar lesion. So there is a problem in the cerebellum. So cerebellar lesions will be suspected in case pendular knee jerk is there. And if the question says there is a progressive muscle weakness where there is upper motor neuron and lower motor neuron and it starts asymmetrically, later on becomes symmetric and the patient can even die because of it. So UMN plus LMN muscle weakness, think of ALS. ALS stands for amyotrophic lateral sclerosis. Unfortunately, not much therapy is available for this. The great scientist Stephen Hawking, he had amyotrophic lateral sclerosis. There is an MCQ on this also. And finally, neurology. Before you ask me, sir, ये इतना बहुत है? नहीं. But this is the one which I feel you can do and you have to do before you sit in the exam. Apart from that, whatever topics you are covered in your guidebooks, go through them, solve some past year questions also. But I have tried to simplify and focus on the things which you tend to lose out on. Before I start with the nephrology scenarios, only 3 or 4 scenarios I will discuss. Only 10 minutes of video is left. I want to emphasize one thing, that before you sit in the exam, if you are watching this video when I'm putting it up today on 17th, so on 18th of January 6 p.m. I will be going live on Instagram. For those, I know you are away from Instagram, but try to just connect with me. I will be live. No academic discussion. I will share something which I feel you should not let go of. Suppose you sit in the exam and there is a question being asked and you have not read the topic. Instead of just blindly thinking of C and marking C or blindly marking D, what things you can apply and still rule out the option and reach the correct answer? Some examples I will be discussing, and obviously we'll just discuss face to face some of the things before you sit in the exam. So only 10-15 minutes session I will take. So if you have time, just try to connect with me, and in any doubts if you have, you can ask me, non-academic doubts, because now it's the time for revision only, right? So let us start with nephrology scenarios. So nephrology scenario number 1, multiple questions asked on this, both in children as well as adults. So medicine, pediatrics, both of them. So examiner will say that there is a patient, child or adult, who's having facial, face pe edema hai, facial or periorbital edema is there, right? Secondly, they will say there is frothy urine, jhaag ban raha urine mein when the person passes urine, and there is urine protein 3+ or 4+ in the patient. So this is 3+ or 4+ protein is nothing but massive proteinuria. So when you have facial edema, massive proteinuria, frothy urine, and nothing is mentioned about hypertension or oliguria or any other thing, the likely diagnosis in the patient is going to be nephrotic syndrome. Nephrotic syndrome, adults, there is no set guideline, right? We say massive proteinuria with edema, that is nephrotic syndrome. In children, it is very clear, the guidelines are defined, and latest OP Ghai 10th edition also says any patient where there is massive proteinuria along with edema occurring predominantly on the face, along with hypoalbuminemia, fall in the albumin level in the blood. What is hypoalbuminemia? If the serum albumin level is less than 3 grams per deciliter. If you find this combo to be present, it is diagnostic of nephrotic syndrome, right? Nephrotic syndrome, can hypercholesterolemia happen? Yes, nephrotic syndrome can have raised serum cholesterol. So raised lipid, raised serum cholesterol can be there, but it is not mandatory for diagnosis. It is not needed. It is not needed for diagnosis purposes, but it is commonly seen, but it's not a part of the primary illness per se. Now, regarding nephrotic syndrome, the causes are often asked in the exam. Now, causes will vary according to whether it is a child with nephrotic syndrome or it is an adult patient with nephrotic syndrome. If it is a child, you will further see that whether it is a primary nephrotic syndrome or it is a secondary nephrotic syndrome. Primary is also called as idiopathic, where no exact cause is found. Primary, most common lesion that you find in the patient is minimal change disease. Why we call it as minimal change disease? Because when you do light microscopy, no abnormalities detected. Only on electron microscopy, effacement of foot process of podocyte is seen. Secondary cause is due to other lesions. It can occur due to FSGS, it can occur due to MPGN, etc. There can be other lesions also. Primary form is more common, 80% cases. Secondary form is 20% cases. Primary form, there is virtually no hematuria or hypertension, whereas secondary form can have hematuria. There will be massive proteinuria to hoga, but they can have hematuria also, and they can have hypertension also. And primary form, in these patients, what will be the drug of choice? In pediatric nephrotic syndrome, the drug of choice is always oral prednisolone. So steroids are the therapy of choice. Steroids produce dramatic improvement in the patient with primary. Secondary response may or may not respond to the patient. And if the question says steroid resistant nephrotic syndrome, SRNS, resistant hai. What is resistant? If there is no response to therapy despite 6 weeks of daily full dose steroid therapy, in these patients the drug of choice is always calcineurin inhibitors. Calcineurin inhibitors. The most effective agent among them is tacrolimus. If that is not in the option, you can mark cyclosporin safely in the paper. And among adults, let us talk about adults. So medicine, they ask you about, they give you a case scenario, or they give you the clue and ask you patient. I'll give you an example. A lady, 60-year-old, having malignancy, weight loss, loss of appetite, and a malignancy was detected. And she also presented with massive proteinuria and progressive facial edema. What is the type of lesion you will notice in the patient? Now, if there is an adult, elderly, and she is having a malignancy associated with nephrotic syndrome, it is likely to be membranous nephropathy, also called as membranous glomerulonephritis, right? So, as a question aate hain, so let us write down as one-liners. What is the most common cause in elderly, age more than 60 years with nephrotic syndrome? It will be membranous nephropathy. Membranous nephropathy. If the question says there is a patient with leukemia or lymphoma, what will be the most common cause of nephrotic syndrome? What will be the histopathological diagnosis? Membranous nephropathy will be seen. If they say hepatitis B virus as well as drug induced, there are drugs like penicillamine, captopril, they all can cause nephrotic syndrome. If you do biopsy, you will find membranous nephropathy to be present. If they say hepatitis C virus is associated with which particular lesion, it can cause membranous nephropathy. More commonly, it tends to produce MPGN, membranoproliferative glomerulonephritis, although membranous nephropathy has also been described in the patient, right? And if they say HIV patient developing membranous nephropathy, HIV tends to develop FSGS, focal segmental glomerulosclerosis, and the underlying condition is called as HIVAN. What is HIVAN? HIVAN nahi, HIVAN. HIVAN stands for HIV associated nephropathy. There is a collapse and sclerosis of the glomeruli, that is a variant of FSGS in the patient. So this clue, this photograph, and the treatment obviously will depend upon the underlying cause. So this scenario covers many MCQs both in pediatrics as well as in medicine. Let us have a look at the next scenario. Examiner will say that there is a patient who's having a facial or periorbital edema. There is a cola colored urine or dark red urine also being passed in the patient. They will say urine protein is mild to moderate. Urine RBCs are present. This is very important. So hematuria is happening along with mild to moderate proteinuria. And oliguria and hypertension may be present. Then in these patients, the likely diagnosis is going to be acute nephritic syndrome, also called as glomerulonephritis. Acute nephritic syndrome, key word to remember is hematuria, microscopic or gross, is always present. Proteinuria plus minus, and proteinuria is mild to moderate, it is not. Agar massive ho gaya, it goes into nephrotic, right? Massive mein hamesha nephrotic, but mild to moderate along with RBCs, it is more in the favor of acute nephritic or glomerulonephritis. Now, acute nephritic syndrome or glomerulonephritis is often triggered. It is often triggered by infections. It is often triggered by infections, right? Now, how would you make the diagnosis if you get a case scenario on this? So suppose there is a trigger infection, and after infection you have onset of hematuria 1 to 3 days afterwards. So there is an infection, and 1 to 3 days later there is an onset of acute nephritic syndrome. The likely diagnosis in this patient is going to be IgA nephropathy. IgA nephropathy, also called as Berger's disease. This is not the Berger's disease with a U, that is a separate, that is a thromboangiitis obliterans. This is IgA nephropathy, Berger's disease. And if the question says onset of hematuria occurs 1 to 3 weeks after sore throat, right, or 2 to 6 weeks after skin infection like pyoderma. In such a scenario, if the gap is more than 1 week, the examiner will say 10 days ago child had sore throat, fever, which was managed with an antibiotic. Now 10 days later he presents with acute nephritic syndrome. Likely diagnosis, yes, you must have guessed it already, PSGN, which stands for post streptococcal glomerulonephritis. Now you need to understand that in acute nephritic syndrome, role of steroids is controversial, not needed in most patients, and even role of particularly PSGN, and even the role of antibiotics is not well defined. So supportive therapy is needed in most of these patients. And PSGN, there is a past MCQ also. It is considered to be a type of type 3 hypersensitivity reaction. So it is a type of immune complex phenomena. So immune complex mechanism is responsible. And PSGN ko kaise pata lagega? Whenever there is a patient with PSGN, that patient will always have low serum C3 levels, which will be a clue in the serum, because complement mediated damage is happening, along with anti-streptolysin titers like ASO titers will be increased, and anti-DNase B titers will also be increased in the patient. These will be additional clues that it is likely to be post-streptococcal nephritis. In histopathology and pathology, you read about the pathological findings, but yaad kar lo, PSGN mein biopsy nahi karte hain. We don't do biopsy normally unless there is a reason for you to perform it, right? So this is the second scenario, and I've discussed some case scenarios here also. And then This scenario. Examiner will say that there is a patient who's having gross hematuria or cola colored urine, mild to moderate proteinuria, sensory neural deafness is present. So nephritic picture with sensory neural deafness. And this hematuria and proteinuria and everything will be episodic in nature. ये हमेशा नहीं होगा, it will be episodic. Patient has sensory neural deafness and eyes are showing a conical shape anterior part of lens called as anterior lenticonus. If this is the picture, the likely diagnosis in the patient is going to be Alport syndrome. It is a type of inherited neuropathy. Alport syndrome, let us discuss a few points. X-linked inheritance is most common, followed by autosomal recessive, followed by autosomal dominant. Some sporadic cases have also been known to occur. But remember that 80 to 85% patients show X-linked phenomena, X-linked inheritance. And what is the most common gene involved in producing Alport syndrome? It is COL4A5 gene. What is COL4A5 gene? It codes for alpha 5 chain of type 4 collagen. And this is responsible. There are other genes also involved, but this is the most common gene involved in producing Alport syndrome. Alport syndrome, therapy of choice. What is the drug of choice to decrease proteinuria? Many of these patients have recurrent episodes of nephritis, and so they tend to develop hypertension also. So drug of choice to decrease proteinuria and manage hypertension, which tends to come in most of these patients by the time they come to medical attention, they are ACE inhibitors. So ACE inhibitors like enalapril are the drug of choice. But remember that there is very little you can do. It's a genetic mutation related syndrome. Case scenario has been asked. This thing has been asked in the INI-CET exam, and this most common gene is mentioned multiple places, can be a fresh question for your exams, right? There are more scenarios I would love to teach more, but the exams are around and I would not be taking that bait. So it has been lovely teaching you all. I have tried my level best to make you revise, but at the same time, whatever we have discussed in these videos is just the tip of the iceberg. I hope you benefit out of it, and the only thing I want from your end is give your best shot, work hard, make it count, and after the exam is over, do discuss with me how the exam was there. We would be doing I would love to do a recall session, and also do stay connected. Once you get selected and you just drop a message saying, sir, ho gaya, it's done, I would be very happy. And all the best for the exams, and do stay connected. I'm here on social media, and for clinical updates, as I said, this is the link that you can follow. So thank you so much, and we stay in touch even after the exams, irrespective of the results. All of you will do good. In case there is any something happened in the paper, nothing to worry, we'll still come back stronger. But right now we have to go with a positive frame of mind and crack the exam. There is no other option. Thank you so much.